But if we screen early, we may diagnose before it presents with symptoms.
Where they are very
and if we do that, then definitely that means we can diagnose early and even treat with minimally invasive interventions, whether it is surgery, that then we can preserve.
So let us all be upstanding. Mashirima Kapombe is going to lead us in this. It's one of her favorite songs, eh? Yeah, so kindly let us be upstanding.
Let's get up, please. I think we go with O'Brien's dancing styles.
Mine is not the best. I can guarantee you that. Mine is the Kikuyu way. And the Kikuyu dance doesn't have anything. You just throw your hands however you want. And for men, it gets actually better when you shake your coat like this. It's called Mazogo than your style. All right? Can you do it Giriama way? How do you do it the Giriama way? Giriama way looks quite sober,
it's
right?
It's the waist.
Eh?
Giriama way is the waist.
Giriama way, you move the waist.
Yes.
Let's see the people blessed with beautiful waists. Oh yeah, all of us are blessed with good waists. Yeah. Kamba, who is from Kamba here? Who is from Kambaland? You're from Rift Valley. Come and guide us. Eh? For them, Dorobo. How do they eat Dorobo?
Dr. Barsito, show us how it's done.
Barsito, come and show us your ways. Eh? Yeah. All right. Come as you pray.
Follow the leader. Our leader is Dr. Barsito. Do what she's doing. Thank you. Tumpigie makofi.
Wonderful. Please come and lead us in a word of prayer.
Dr. Fahad. Dr. Fahad. Is Dr. Fahad here to come and lead us in a word of prayer?
Sure.
So that we can begin.
Wow, you people can dance. Serious.
Let's remain upstanding for the prayer.
Hello everyone, good morning. We are going to pray the Islamic way. So I'll invite my fellow Muslims to participate. We are going to read the first chapter of the Quran. It's the opener. So Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir Rahim. Maliki Yawmiddin. إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. May God bless this gathering. May we have a fruitful day. And as we leave this gathering, we go peacefully to where we've come from. Thank you so much.
Amen.
So today, as I alluded to, is our third day here, and we're about to get into our first conversation of the day, and Mashirima Kapombe will be guiding us through that. And again, remember yesterday we had a great session with the king of condoms. I'm reliably informed that the queen is around, and so she'll be taking us through another exhilarating session. It's something you don't want to miss. So let's get ready for that. Plus, there is going to be a surprise at the end of this our program today. So you had better stick around. So Mashirima, please.
Today's first session, actually, O'Brien, is very close to every woman's heart. It's about cervical cancer screening. And I think all the women here can agree with me. And I wish the doctors can tell us if they will ever come up with another way to do the screening. Because I can tell you for sure, those who have been through it, it is scary, it is invasive. I see some jokes people make on social media that when you go to your gynecologist, he or she gives you a minute to remove your underwear, and you have your privacy for like 2 minutes, and then he comes with a torch. So you wonder, what was that privacy for? And for many women, it's either the frightening bit, how invasive it is, or maybe it's about religion or how we are socialized. So allow me to welcome the session chair for this session, which is Closing Gaps in Cervical Cancer Screening, Dr. Visva Pillay. Dr. Pillay is a seasoned medical scientist and the Senior Medical Affairs Manager for Integrated Diagnostic Solutions at BD. Overseeing the Middle East, Africa, and Turkey, he holds a PhD in medicine for the University of Witwatersrand and brings over 27 years of combined experience across academic research and the in vitro diagnostics industry. Let's give him a round of applause as he makes it to the stage. His panelists will be Dr. Victor Kibe, who's the head Division of Non-Communicable Diseases, Department of Preventive and Promotive Health, Nairobi City County. He's a pharmacist and health economist with extensive experience in infectious diseases, quality assurance, and health systems strengthening. Let's give him another round of applause as he comes to the stage. And finally, Professor Matilu Mwau, who is a leading infectious diseases researcher and senior clinical scientist at the Kenya Medical Research Institute, that's KEMRI, where he also serves as Deputy Director of the Center of Infectious and Parasitic Disease Control Research. Let's give him a round of applause. Ni kama tumechoka na hatujaanza. Tuwapigie makofi mazuri tafadhali. Asante. Karibuni.
Good morning, distinguished guests. It's my absolute pleasure to welcome you to today's session. We know that cervical cancer continues to claim lives, especially where access and screening and care is limited. And today we'll hear from our panel of experts who are working to change that through innovation, advocacy, and importantly around community-driven solutions. So thank you for joining us this morning in this conversation. We're going to change it up a bit today because it's not primarily a panel discussion, but we'll have our two experts presenting to you this morning. So first off, I'd like to invite our first speaker, Dr. Kibe, who will take us through some work being done in Nairobi County. Dr. Kibe.
Good morning, ladies and gentlemen. Good morning. Yes, it's a pleasure, and I'm humbled to be here today. And I want to first and foremost say that what Mashirima has just said is quite true, and that's why we are here to see how we can change that narrative, how we can close the gap in terms of cervical cancer screening. And yes, we've adopted with technology, innovative ways to make the process more friendlier, so that it also comes with the dignity it deserves, so that it also we are able to reach as many women as possible in terms of cervical cancer screening. So I'll take you through a presentation on cervical cancer space and what is happening, although I'll also give an overview of what is happening in Nairobi County, just so that even as we speak to other dynamics of the disease, we also get to see how preventable it is and what are some of the Yes, so what are some of the possible ways that we can become even more ambitious so that we are able to have a proper and better coverage? So my name is Dr. Kibe Victor, as Dr. Vispa has said. I head the Division of Non-Communicable Diseases in Nairobi County under the County Health, Wellness and Nutrition sector, and I'm privileged to have been working in this space for the last 8 years. This is just an overview of our county. Nairobi has 17 sub-counties, distributed all the way from Kasarani, Roysambu, bordering. Of course, we border Kiambu, Machakos and Rongai. And just to say that we also receive a lot of disease burden, especially for cancer from across the country. So what we may present may not precisely be just for Nairobi. It might also have a representation of figures from other counties which refer to Nairobi, because we are, of course, have the highest infrastructure in terms of treatment and diagnostics. So according to the last statistics, our population is approximately 4.3. Of importance to mention is that Nairobi has two populations, a population by the day and a population by the night. Currently, we are talking about over 5 million because there is that movement during the in and out of the day. So basically, that is how the landscape looks like. And you can see we have even the geriatric population as well as the very young ones. Yes? Someone to? Okay. Yeah, so in a nutshell, this is how the top 10 cancers in Nairobi County, this is how they look. By gender, we have the leading one being breast for female, and of course for men, prostate. That's how the narrative looks like. Those are the various cancers, the top 10 that are being reported in. But of course, today our main focus is on the cervical cancer, which we'll be speaking into as we move forward. So this is just another overview that differentiates the two, just to show the male and female and what are the leading cancers. So I'll not belabor you with that. Those are figures we can discuss much later and engage with. Of course, you notice that breast cancer has the highest prevalence, followed by cervical cancer in women. However, of importance to mention is that cervical cancer has the highest mortality compared to breast and all the other cancers in general. Now, this is just another presentation that shows the specific incidence rates. Our importance, of course, is the graph, the graphical presentation to my left. The orange one being the cervical cancer, just like I mentioned. The burden is higher with breast, but with mortality, cervical cancer is what is leading, and that's why we are really interested in trying to see then how do we stop, because this is one of the cancers that is preventable through various interventions, and one of them is the screening part, because when the screening is done and the suspicious lesions or signs and symptoms are caught early enough, then of course it can be done. And then of course we have the immunization, the vaccination for the girls. So the screening status and what we've done, and this is our investment as the Nairobi City County Government, the Health, Wellness and Nutrition sector. We have been deliberate to train and build the capacity of our healthcare providers such that they are able to, not just at the facility level, but also at the community level. So our capacity building aspect has not primarily been focused on the healthcare providers. We've also built the capacity of the community health promoters. This is in alignment with the universal health coverage and the primary health care, such that we are able to screen at the community level. And I think this is where it gets sweeter, because this is where now we see we don't have to wait for our clientele to come to the facility. We are getting them at their household levels. We are getting them at their comfort of their homes. So beyond that, of course, we have a pool of our trainers who just don't train. They also do a lot of mentorship for healthcare workers. And these are people who we are constantly engaging with. So as a county, in terms of infrastructure for diagnostics and early treatment, we have 14 cryotherapy machines in 14 primary healthcare facilities. That means we are not just leveraging on the level 5s, we are going down to level 2 and level 3. You can walk into Makadara Health Center, for example, you can be examined there. If there are any suspicious lesions, then you can get and be able to access the treatment there. However, we have also built the capacity of our level 5 hospitals, that is Pumwani, Mbagathi and Mama Lucy Kibaki Hospital. And we also leverage so that we just don't look like we are so much focused on our county facilities. We are also working hand in hand with the faith-based institutions. And so far we've been able to partner with St. Francis Hospital and Uhai Neema Hospital. We've provided them with the necessary treatment gadgets. We've trained their staff and we continue mentoring them, and as we try to widen the scope. Of course, we are also aware that we are working closely with the private facilities. We just recently concluded a study on the infrastructure there, which hospitals are where offering what kind of service. This is in terms of whether it's radiology, whether it is surgery. We just concluded that, and we had a dissemination on the same just a few weeks ago. So now, I think this is very important because this data is how we performed as Nairobi County for the year 2023. And as you can see, we have the various screening strategies. I would want us to take note of the first column. That is the number who was screened via Vili, which is the most common and adopted procedure for this. And then on the far left, we have the number of women who had suspicious lesions. This was across the year 2023 because it's important that when you compare that data now with the 2024 data, I don't know whether you're able to see that there is an increase. This is, of course, coming from the screening bit. We've scaled up our screening. And again, when we screen more, you realize that also the clients with suspicious lesions, their numbers also increase. You may want to know, so then what happens to the ones with suspicious lesions? So we have a referral pathway where we have a multidisciplinary team approach. The clients are taken through trying to make it as better as possible to see that a woman can take a sample, not to screen, can take a sample from the comfort of their house. Isn't that excellent, ladies and gentlemen? Yes, from the comfort of their house, they can, we avail the sampling kit. We explain to them, and that's the reason why we had to build the capacity of our community health promoters. We explain to them that this is how it works. We demonstrate, and then we give them the kits. They can go do it from the comfort of the house, and then they bring it to the nearest facilities. And then from there, we pull this together, and then we send them to the laboratory. Previously, one of the biggest challenges, and I know maybe some speakers who have been here earlier have told you, is that we have a very long turnaround time from the time the sample is collected to the time you get your results. Now, with this innovation, we are trying to see how that can be reduced. And evidence has shown that with the self-sampling and the pooling of our resources and the infrastructure at the National Oncology Reference Lab, we are able to reduce that turnaround time from 3 months to around 2 weeks. So that makes it easier, and then we are able to get back the results, and then we are able now to cancel and disclose these results to the clients. And then, of course, those who are found to have positive results, we do the necessary multidisciplinary team approach. For those who require referral, if you're not able to provide that service at our level, then we are able to refer them appropriately or to a facility of their choice. This is happening at Mama Lucy Kibaki Hospital and the environs. We've trained 700 community health promoters. which tells us we have quite a big gap in terms of building the capacity for the same. I'm happy to say that yesterday I received some communication that we are getting some kits through the program, the National Cancer Institute and then NCCP through KEMSA. This will go a long way in, addressing these issues so that we can push as many people to be able to access this service. Of course, this comes also with the advocacy. There's a lot of myths and misconceptions. So then we try to see how we are able to demystify and make it easier and acceptable. Out of the work we've been doing, we've been able to have some preliminary findings. These are from the labs, and you can see that on average we have a positivity rate of 30.7%, out of which HPV 16, which is the most virulent of the genotypes, is at 5.2%, followed by, again, HPV 18 at 14.2%, and then we have the others lumped at 80.6%. And I think one of the important things and how we plan and the plans that we have is that how do we unpack the 80.6% so that we also get to know which are these other circulating strains, and then we see how to address that. But then you can see from the results that we've so far achieved, that is how the landscape looks like. And we are trying now to see how do we close the gap by doing more screening and achieving this. So this, of course, has not been a smooth ride. We experienced the very common, obvious challenges of stockouts once in a while. But then we are trying to build resilience, and like I just mentioned yesterday, we were informed that there are some kits that are available that we need to access. Of course, the reporting area is also not very friendly because we only have registers that can only do as much, and then of course we have transcription errors, which means we really need to do a lot of data quality analysis and service quality analysis as well, so that the information that we are using for evidence-based decision making then is the right information. So this is work in progress. We also continue doing a lot of supervision, and like I mentioned, I would wish that all of us become ambassadors and advocates of demystifying the myths, because you realize the uptake, especially for the HPV vaccine, is quite low, not just in Nairobi, but countrywide. How I wish we would be able to scale up to have as many girls, because like I have mentioned before, this is one of the cancers that can be prevented, and I know the vaccines are available, our young girls are available. The access is the issue, and the issue around that is advocacy to see how then we can engage them through the various gatekeepers, starting with ourselves. So community mobilization, again, this is something that we really need to work so that we can reduce the long turnaround time among training among the clients. And what we wish is that if we were able to train out of the more than 6,000 community health promoters that we have in Nairobi, as many as possible, then it will be good. I wish just before that, I say that in one of our sub-counties, one of the best practices is that we have adopted with the community health promoters is that all the community health promoters who are eligible for HPV vaccine, we've actually, not vaccine, but screening, we've actually availed them to them. And they took it positively so that even as they go and spread the message, then they know what they are talking about. I think this almost brings me to the close. This is just a disclaimer that these are, and I would really like to appreciate the support that we got from the National Cancer Institute, BD Diagnostics, Health Strat, Havas, who have been part of this project, as well as the National Cancer and Control Program. Thank you, everyone, and that brings me to the end of the presentation. Asante.
Thanks, Dr. Kibe, for setting the scene around Nairobi County and what's been going on, as well as highlighting some of the key innovations from a community-driven solution of using the healthcare promoters and as well as utilizing self-sampling as a means of improving access. I think we're going to continue now on the innovation pathway, and it's my pleasure to welcome Prof. Matilu that's going to speak around what the utilization of extended genotyping for HPV screening can bring in terms of closing these gaps. Prof. Matilu.
HPV, but we just haven't had the interest until very recently. I work for the Kenya Medical Research Institute, where I deal with infectious diseases. We have, spent most of our lives looking at HIV, arthropod-borne viruses, and coronaviruses and stuff like that, hepatitis. But it's only recently that we began to pay attention to HPV, especially because when we went to meetings like this and conferences, there was quite a bit of noise about, how people are dying, how people are suffering, and then we've been asking ourselves in my research group, is there nothing we can do about HPV? And I'm happy to go through with you some of the thoughts that we have and see whether we can have some congruence. I don't know how to operate the slides. That's why I came with my laptop. I was very suspicious that they wouldn't display. Oh, thank you. So first of all, I would like to start by saying that what I'm going to present is what I'm thinking. I haven't been helped to think by BD, and also they didn't help me write the slides. I did them myself. But there is something else I would like to say. So, because some of the data that I'll present here I have not published yet, it will be nice if you do not circulate it so that, I'm not preempted by, the way the business of research works. But as people are in the biomedical sciences or at the interface between medicine and science, and for the purposes of this meeting, we are looking at the cervix. And I'm hoping that you can see what a healthy cervix is. That is the cervix on the, does this thing work? That's the cervix on the left. That's how a healthy cervix looks like, all right? Now, the cervix on the right has some problems, okay? You can see lesions. Even if you are not an obstetrician, you're probably not happy with what you are seeing. And if we dig further, we will be able to tell that those lesions are related to HPV having been there for quite a bit of time, all right? And this is what we do not want our women to be having when they are walking in the streets. This is the business of science, and this is the interface between the science and the medicine. For those people who have been in the human anatomy, maybe you can see the external os, you can see the ectocervix, and you can see the transformation zone, but you can't see the endocervix from here, I suspect. But that is just something that may interest some other people here. The virus that we are talking about is the human papilloma virus. And for those of you, again, who are in the lab, I can see a few here, you know that it looks round if you have the right equipment to look at it, all right? And if you're able to measure the size in terms of the diameter, it's probably around 35 nanometers, okay? And it has got a double-stranded DNA genome, all right? And you may also know that there are many HPV types. These viruses are very many. The last time I checked, there were maybe 400 or 600, and people are still discovering others. They in fact can think about, but they are specific to specific animals. So like for humans, we have human papilloma. They infect other animals, mammals, even birds, snakes, turtles have got these viruses. But for you, you should know that the one from a snake, for instance, will not infect you. You'll get HPV from another human being, right? The ones that infect humans, some of them cause lesions that will not become cancer. So for instance, if you find you have a wart on the foot, that wart is not likely to become cancer. It could, for other reasons, but not likely. But if you have those ones that infect the cervix, you could get cancer, okay? For instance, you have 16, 18, 31, 45, and so on. we say you have those high-risk HPVs, the ones that are quite likely or more likely than others to give you cancer of the cervix, okay? They can also give you infections of the anus, of the penis, and so on, of the throat, but the business we are in here right now is the ones that cause you cervical cancer. So I checked not too long ago, and I found that more than 600,000 people had got a new cancer of the cervix diagnosis in 2022. Maybe there is newer data than this, but 660,000 people is not a small number. And I also found out that 350,000 people died in the same year because of cervical cancer. 350,000 is not a small number also. And even more importantly, a majority of these problems occurred in our neighborhood, where the people don't have so many resources and where the systems are still getting defined and established, okay? In 2020, Kenya had just about something like about 5,000 to 6,000 new cases of cancer of the cervix. And from the data that I'll show you, high-risk HPV, the HPV types that can give you cancer, those sorts of infections of the cervix are very common in Kenya. I'll show you that data. One of the problems we deal with is that in many countries that are not well-resourced, like in sub-Saharan Africa, the screening programs for cervical cancer are in their nascent stage. So we are still struggling with what to do, when to do it, and how to make it efficient. And that problem reflects in the level of morbidity and mortality associated with cervical cancer. Of course, there's the low screening problem, and this is where us people as a lab come in. And there are many facets of that problem. The first facet is at the micro level. In our part of the world, individuals tend to, for instance, have issues that prevent them from accessing screening that are individual to themselves. So, for instance, they may not believe that disease like cervical cancer is associated with the natural sciences. They might, for instance, say it's supernatural, okay? Then there are community level issues. So our communities tend to be quite patriarchal, and so sometimes women lack agency because they are living in an establishment where the man has the say. And then now we have got the bigger level issues in terms of like infrastructure, referral systems, service delivery systems, financing. Kenya, for instance, doesn't have much money for health, as you can see. And then the leadership and so on. There are many macro challenges that we need to deal with. But as people, in the biomedical sciences, we are in the space that can help you improve the testing for the screening from what has been done traditionally by doctors or gynecologists to what now you can do for yourself and get it to us, and we can get stuff done. In this slide, what I'm showing you is that high-risk HPV is very common in Kenya. We took our time and went to some counties like Bomet, like Kisii, Nyamira, Embu, Busia, and we collected samples during medical camps that were being coordinated by people from the Moi University side of things. And our intervention there was to provide this service. And what we found was quite interesting. So we were able to collect samples from 755 women who came to these camps basically feeling okay and just getting a blood pressure or blood sugar and so on. And we found that overall, almost a quarter of the women had high-risk HPV, okay? And this is actually supportive of the data I've seen from my colleague from Nairobi County, that 30% had high-risk HPV. Now, knowing that some of those HPVs will go on to cause cancer is something very concerning. And they even had the high-risk HPVs that are most dangerous, 16, 18, even 35, 31, they had them. And we wondered, and we in fact began to pay much more attention to HPV at that point. We used two kinds of assays. One was a BD Viper assay, the other one was the Abbott assay, which we have these resources in the lab. And whichever assay we used, high-risk HPV was a common finding among those samples. And then, so that helped us begin to have some preliminary thinking about HPV. And the first thing is that we know that WHO prefers HPV DNA detection as a primary means for screening. Now, in our environment, we have been doing VIA, we have been doing cytology for those who have some resources, we've been doing other stuff, but WHO prefers HPV DNA screening. And there's a reason for that. The evidence is overwhelming that HPV testing is much more protective than cytology in terms of morbidity and mortality. It's much more protective, okay? In fact, HPV DNA testing finds twice as much disease as cytology. And so you don't want people to come, you test them, and they go home having disease and you don't know. So HPV testing helps to close that gap, okay? And then there are many assays that can help us do this, but most of the assays that are available in the laboratories will help you detect HPV 16 and HPV 18 and maybe 45. And some of them will put HPV 18 and 45 together, so when you get that result, you do not know whether it's 18 or 45 or the both, okay? But there are some other assays that give you a bit more extension to that capability, so which we call extended genotyping assays. And those ones will help you detect 16, 18, 31, 51, and 52. These are the most dangerous of the subtypes. Now, there's something to be said about those assays. The vaccination that you get for HPV, that vaccination may help you not catch 16 or 18. So in the future, if you have assays that are detecting 16 and 18, and you've been vaccinated, then you may miss out other subtypes that will be the big problem for you because you've been vaccinated. So there are limitations to how long we are going to continue using those assays that detect just those two, all right? Now, there are some assays that are even a better, coverage of the subtypes that are important to us, and they can detect six high-risk HPV genotypes individually, and then they can group the other dangerous ones in groups. Like, for instance, one of the assays that is commonly available is able to detect 6, that is 16, 18, 31, 45, 51, and 52, and then it also groups the other dangerous ones in groups. But ideally, in the future, we are hoping that a time will come when we have assays that can do full genotyping. But for now, extended genotyping really covers those subtypes that are most dangerous to us. And there's a reason why WHO has recommended that going forward, all assays should actually offer extended genotyping. And one of the reasons is that as I said, HPV 16 and 18 will become less important with time, while the rates from other high-risk HPV types may rise. And then, so for that reason, extended genotyping will become much better suited to monitor these changes and also to become an effective tool for cervical cancer screening. And then extended genotyping will actually help you reduce unnecessary medical interventions. We have data also to show that when you compare with cytology or the traditional approaches, it will help you reduce the amount of money you expend screening for cervical cancer or treating cervical cancer. And also there is the issue of the psychological burden to patients and financial burdens for some of these things that extended genotyping is going to help alleviate. So apart from the recommendation around HPV DNA typing being the preferred approach, WHO generally has no bias with regard to what you should do after that, as long as you get some intervention. So there are some approaches that are screen and treat, then there are some approaches that are screen with HPV DNA genotyping, then bring in a second triage test, and then from that intervene. So both of those approaches have got similar benefits. They cost roughly the same, or maybe with just a small difference, but when you look at the overall benefits, they match. So WHO does not have a bias with regard to whichever approach you use after that. There's more than 20 years of evidence, as I said, that shows that HPV screening detects twice as much disease as cytology, and is much more specific. So what that means is that if we do HPV DNA screening and we tell you you do not have a high-risk HPV type, we are probably speaking the truth. But if we do cytology and we tell you we didn't find something, we are possibly speaking the truth. Do you understand what I'm saying? But when we do HPV DNA screening and we tell you don't have, we are confident when we tell you, please come back after 5 years, go and do your thing and come after 5 years. So HPV screening allows less frequent attention from the medical, interveners. This, because HPV DNA is a recommendation of the WHO, Kenya has adopted this approach, okay? And now, it's easy for me to say that, but when I went to the field, I actually found that the common approach was VIA. In fact, not even VILA, just VIA, because they said acetic acid is easy to get, and Lugol's iodine appears to be a bit tricky to procure, I don't know. But whatever the case, when you do VIA and you find the person is negative, according to the Kenyan algorithm, they can go and come after 5 years. I think WHO is 3 years, I can't recall, but for Kenya, if you are VIA negative, go away, come back after 5 years. And if you are positive, then things will be done for you, but sometimes they can do, and then they see that here there's cancer, and then there are interventions. Now, because of this recommendation from the WHO, Kenya has introduced HPV DNA testing, and I can see in Nairobi they have done some of it. And even after HPV DNA testing, again, the approach is when you are negative, you can go away and come after 5 years. But if you're HIV positive, then you should come more frequently. That makes sense because the risks associated are much more immense, okay? And then if you are positive, then colposcopy may be available, not available. If it's not available, then you can have VIA. So you can triage with VIA, but if colposcopy is available, then interventions can be implemented. And that's a good thing for Kenya, but from the look of it, as you can see here, it looks somewhat complicated, and also it has not brought in the benefits associated with the extended genotyping. I've looked at groups or the places where the people are much more resourced and have brought in extended genotyping to see whether they can improve the algorithms. And the first one to the left is the enduring guidelines that have been suggested by teams in the United States, the Association for Screening for Cervical Cancer. And in those guidelines, you can see that they have extended genotyping. If you are found with 16 or 18, or the both of them, you cannot be told go and come back. On the spot, colposcopy and interventions, okay? If you are found with others, then there are various interventions that are guided by what you find with extended genotyping. So actually, this is a good thing because if a person has got HPV 16, for example, if you decide to check the cervix at that point, you will discover that more than 23 or 25% of those people have got CIN 3+ onwards, okay? So it makes sense for you not to fail to intervene. And then for the other high risk, but with the lower incidence of CIN3, then there are other interventions. The suggestions on the right are from South Africa, from a group that has done some work in South Africa and suggested that, in fact, HPV extended genotyping is sufficient for you to intervene. So you can see there is no triaging in this suggestion, that you just do HPV. If you are negative and you don't have HIV, you come after 10 years. If you are positive, you come after HIV positive, you come after 3 years. And the duration that it takes for you to be brought back has something to do with the fact that it takes a bit of time if you catch HPV or you get infected for you to develop some of the problems that are visible. So several years. These are slow-acting viruses. So these recommendations could be useful to us in Kenya in the future, especially because these complex algorithms have shortcomings. And number two, the resources that we have do not allow us to, for instance, triage like with cytology for everybody and so on. So, and the other thing is that when approaches like this are done, there are some research work that has been done to suggest that the costs can even be reduced by more than 10%, number one. Number two, you could end up getting an increase in the number of patients visiting clinicians that have the highest risk HPVs. The increase can actually be somewhere between 50 and 100% increase, while reducing the people who have low risk HPV that are going to see clinicians, actually, so that you end up with just about up to 6% of the people having low-risk HPV and going to see a clinician, basically accessing resources they shouldn't be accessing, okay? So, and then the other thing is that an approach like this one, or even either of them, can reduce the number of people who are required to come back after 1 year and yet they have CIN 3+. When a person has got CIN 3+, they should be dealt with on the spot. Previous approaches will cause some of the people who have that to slip through the cracks, but this kind of approach will help those who have CIN 3+ to get treated on the spot, okay? So the final thing that I want to bring to your attention is that my colleague from Nairobi has mentioned self-collection. We did some work around self-collection, and we have no choice but to recommend it very strongly. We have no choice, because in this experiment, in the places we went, in the counties, we collected around 128 samples. We told people to collect for themselves and give them to us. And we compared what the results they had with what the results the clinicians had. So the clinician also collected the sample from the same person who collected from themselves. What did we find? I think you should pay attention to this slide. It looks complex, but it isn't. So at the bottom there, you can see that for the left side, we had a total of 127 people where we were able to do some analysis. If you look at self-collected, you'll see that they told us from those samples, 42 were positive for high-risk HPV, 42. But when you looked at the samples collected by the clinician, only 24 were positive, okay? Even when we used a second assay, the people who collected the samples, from those samples, we found that 47 were positive. But when we looked at the clinician collected samples from the same guys, only 33 were positive. This science is well established that when people collect samples from themselves, the high-risk HPV yield is higher than when clinicians collect. There's a reason behind that, and it has to do with the fact that the clinicians go for the endocervix, and whereas I suspect the ones who collect for themselves go for the vagina and the posterior fornix and so on, where there's much more virus or something like that. This data has been shown by other people in other studies, so we didn't invent anything here, but the only thing we can say is that we really strongly recommend self-collection where possible, okay? So what are our final thoughts? The first one is that, HPV DNA will become the primary screening test for most, not reasons, but for most people at some point to just be HPV DNA detection. And then self-collection, as I've said, presents distinct advantages, and therefore it's something that you really need to adopt. And a coherent national testing program is urgently needed. I can see some movement in that direction, which is really good. And people like us who are in the lab sciences can actually support that kind of program very strongly. Screening algorithms will need to accommodate extended genotyping, because extended genotyping is much more efficient, and it will help us, of course, get more referrals for treatment or further triage, which is a good thing. And although we'll have many more people accessing these services through extended genotyping, the fact of the matter, it will be more efficient. Clinicians will see many more people coming to them, but those people will be having the highest risk genotypes, and very few people will be coming with the low risk genotypes. In any case, those people who have got CIN 3+ and above will be seen probably the first time they are screened, which is good for everybody. I work for the Kenya Medical Research Institute, and I don't work alone. In fact, I probably don't work much. There are people who actually generate the data that I'm showing you. I really appreciate your attention. Thank you.
Thanks, Prof. Matilu, for continuing that discussion and showing how innovation is slowly trying to close those gaps within cervical cancer. I see we still have some time, so I'll open the floor to questions if anyone has any questions to our panelists. Can we get a mic, maybe?
Hello and good morning. Thank you for good presentations and the information you've shared, especially on issues of cervical cancer screening. My question is just to add on, some of the things that have been raised, especially when it comes to access, screening, and even treatment. There's a major gap, especially when it comes to patient navigation, and I think it's something that could help us to be able to find a way to navigate these patients, because most of them really, if they get the information and they are aware about the risk of cervical cancer, they are willing to get tested. But once they're introduced to the system, screening, and then somehow they get lost on the way, then it beats the purpose of, all this investment you're making. So how do we make sure that, we navigate our patients very well, and we have very good resources? I'm seated here with very beautiful ladies, the survivors, who actually could be doing this already, but we need to get to a point whereby, as a country, we lay out the plans in terms of how do we navigate these patients to ensure that they get to a point whereby they are linked to care and they are helped in the best way possible. Thank you.
Thanks, and I think that's a really great question in terms of what do you do with the woman once screened? Screening is just one aspect, but how do you follow up and get them to complete treatment, right? And I think from Nairobi County, there's some examples of how they're utilizing the community health promoters, but maybe I'll ask Dr. Kibe to comment on that.
Yes, thank you for that question. And true to what you've said, we've had so many challenges with client navigation. And what I can say is that we are currently conducting a study on the same, just to find out what happens, what is the journey from the time the patient is screened to the time they get their results and they are able to access the treatment. The study, I think it's in that year. We are doing this with the National Cancer Institute and Nairobi City County Government. So this will help us to make more informed decisions rather than do a lot of guesswork of what could be the issues. However, we know, like Prof. Matilo has said, we have some systemic issues within our institutions. And we are looking at how are we able then to track these clients right from the time we screen them to the time we give them their reports to the time if they require treatment, they are able to. So I can say that a study is ongoing on the same, just so that we are able to make more informed decisions. However, like Dr. Vishay has said, we are working with the community health promoters because they know these people at the household level. So if we get your sample and we are not able to trace you back, then we use the community health strategy to be able to track you down so that we can be able to access you, especially if your results were positive with the two highly virulent HPV genotypes. Thank you.
Thanks, Dr. Kibe. I see we have a few more questions.
Good morning. Mine is somewhere between Forest Road and Ojijo. There is Nairobi Cancer and Diagnostic Center. So kindly tell us, when was it open, the services that are offered there, and who is there? Because I think there is no linkage between what is written, what is colored to be a center, and the services. Thank you.
Dr. Kibe?
Almost so that at least when we respond, we don't spend so much time. I think my just suggestion.
More questions?
Good morning, everyone. My name is Sally. I am a cervical cancer survivor, and the diagnosis was in 2007. And I'm alive today. The pain of cancer is pain that I wouldn't wish my worst enemy. And I would like to urge all the ladies in the room, let us get screened. Because when I was screened, I did not have a single symptom, but I was already in stage 2. I turned positive for the HPV virus because I'm also living with HIV. And so it was critical that I go for this screening. So please, let us not wait for pain. What is killing women is because we are waiting for the pain, we are waiting for the symptoms. But I was eagerly waiting to see if there was going to be any slide on survivorship, because cancer still remains a death sentence to many people. Are we in agreement? Yes. If you hear the word cancer, you know you are dying. But we are here as survivors. If we could get data on people who have survived, like how many women were screened and treated and survived. I've survived since 2007. How many others? That would be very encouraging to women who have not gone for the screening. And when we talk of if you are found to be negative, you wait for 5 years. I'm just wondering, this is a virus. For example, with HIV, if you are tested and you are negative, you are told to come back after 3 months because there's the window period. I'm just wondering, with HPV, there's no window period, because for me, 5 years is a very long time for someone who's sexually active. Thank you.
Thank you. I think we have a question from Dr. Melly.
Well, thank you very much, our two presenters, Dr. Kibe and Prof. Mine is not a question. It's an addition to responses Dr. Kibe gave on patient navigation. Really, there's a lot of effort and progress in that space from a national perspective. I do appreciate working very closely with Nairobi County. There is so much progress we've made there. During the opening ceremony, you remember we launched the transfer of the Empower program from our partners to the National Cancer Institute. And this is going to be rolled out across the country. It is very sensitive to digitization, and data is at the heart of this Empower program. This is how we will make sure everybody who is screened across the country is not lost. We will be having the feasibility, from screening and navigation to care. And beyond that, because, we are using digital tools, we will find you where you got treatment, and we will find the outcome of the treatment. And this will generate for us data, including survivorship. And in soon future, we should be able to publish all the data as requested by Sally, who has been a great champion, for our patients and a great encouragement. So rest assured, from the National Cancer Institute perspective, we are on it, and watch this space.
Thanks, Dr. Melly. I think that's really commendable and great in terms of what's actually currently happening in the space in Kenya. Maybe one more question.
Good morning, everyone. My name is Millicent Kagonga, and I would love to ask my question when I'm in this table. So we say numbers never lie. I'm a cervical cancer survivor and the HPV vaccine ambassador. My daughter being the one to get the HPV vaccine in Kenya. As I said, numbers never lied. Dr. Kibe, you have showed us the numbers, how in Nairobi County, and we have seen Embakasi East and Embakasi North, how they are doing. And I know you're asking yourself how, but it is because of this table. Most of us, we are coming from Embakasi East and Embakasi North, and we took it upon ourselves to go from door to door, from house to house, to tell them the importance of cervical cancer screening and also the importance of them going for the HPV. We are cancer survivors, and we never want others to go through what we are going through. I'm glad we got the opportunity to be part of it. But I would love to say that we still have a long way to go, because as I know, if we raise our voices, we make changes, because our voices matters. Thank you.
Thank you. I'll open it for one last question.
Good morning. My name is Dr. Becky, a breast cancer survivor from Wasingishu County. Thank you very much for the presenters. And I am on the ground. I say, jogoo wa kijijini hawiki mjini. So I'm learning a lot from mjini, Nairobi. But down there, when you talk about cervical cancer screening, really not so many people turn up. And I'm happy to hear about self-collection of sample. How can this information reach to us in the western region or other parts of the county? How can our people be empowered so that we can be able to collect as many samples and they can be assisted? Number two, I realize there is a major gap. People are being screened late, maybe stage 4, stage 3. And for those who have been treated, know the impact of that treatment. I go to hospitals. Like I go to a hospital called Gynocare in Eldoret. You find women who have developed fistula because of the treatment. How can we be able to reach to these women so that they can be treated as early to alleviate this kind of impact? And finally, how can we come in? Do we have organizations that can help these women get diapers? That is a major frustration among those who are surviving with cervical cancer. Thank you.
Thank you. I think that's touched on a broader thing that Dr. Melly and
Thank you. I think that's a question that can be responded, let me rescue Dr. Kibe and Prof. Matilda from this. Yeah, but at a fee. Okay, so we have a national strategy on how to communicate. You do appreciate that the Constitution of Kenya 2010 devolved healthcare to county governments. And when you see the work Nairobi County is doing, it's because the county government has taken, the bull by the horns to face this directly because they've appreciated the burden. And what we are doing right now is to sensitize all our county governments. And we've been having a lot of engagements with community health promoters whenever we are doing community-related activities. And this is work in progress as well, because the oncology module is being integrated in community health promoters modules, so that as they are our first level 1, healthcare workers, they should be able within their 100 households educate, because that is the only best strategy to reach every woman who is, all over the country, from Lamu to Busia, Migori to Turkana. That can be the only way this information can reach. And this is, again, work in progress. Sensitization is going on. Over the last year, we've had sensitization activities across many sub-counties in this country. And you realize that we have, more than 300 sub-counties in the country. So we've sampled a few, and as we mobilize resources, from our national cancer control strategy, we need over and above, 300 million to execute this, and working within the partnership between the national government and county government budgets, including our partners, we hope to make incremental progress. And in due course, this information should be across the country, and we wouldn't want to leave any woman who is eligible for screening behind. Thank you.
Thank you, Dr. Melly. I think, distinguished guests, colleagues, thank you for your time this morning. As we conclude, I want to leave you with a statement by Michelle Obama, who aptly stated, "Communities and countries, and ultimately the world, are only as strong as the health of their women." So let us take this as a call to action to continue advancing equitable access, early detection, and comprehensive care for all women. And thank you again to our speakers and all of you. Appreciate your time and dedication to this vital cause. Thank you so much.
Well, I think the panel deserves a better round of appreciation. So let's clap for them. And of course, for the people who are bold enough to raise questions. And I think what is coming out of this conversation is the fact that we need to enhance testing and diagnosis so that we can arrest the various forms of cancer, at a better stage. So thank you very much indeed for that presentation. We're now getting ready for the second presentation of the day, which is going to be guided by Dr. Irene Jerry. Is she in the meeting? Yes, please. Please come up on stage. Dr. Irene Jerry Moshoki serves as the Chief Officer for Medical Services in the County of Nairobi. In her leadership role, she oversees clinical policy implementations, coordinates county medical facilities, and drives up public-private partnerships aimed at improving health services across Nairobi's network of health centers and referral hospitals. She previously served as the Deputy County Director of Health in Nairobi County, and she holds a Doctor of Pharmacy and an MPH degree from the University of Nairobi. She has also previously served as a chief pharmacist at Mama Lucy Kibaki Hospital. Please, let's appreciate Mrs. Jerry. Also coming up on stage is Dr. Dulcie Wanda. She's this is a radiation oncology, head of oncology department at Nakuru County Referral and Teaching Hospital. Do we have? Yes, yes, she's coming up on stage. She is a clinical and radiation oncologist leading the oncology department at Nakuru County Referral and Teaching Hospital. She oversees comprehensive cancer services including chemotherapy, advanced radiotherapy, and supportive care. She holds a Master of Medicine in Radiation Oncology from the University of Nairobi, a Master's in Organizational Development from St. Paul's University, and a medical degree from Egerton University. Please, let's appreciate Dr. Dulcie. Also coming up on stage is Dr. Duke Mogaka, a clinical and radiation oncologist from Samburu County, a teaching and referral hospital. Do we have Dr. Duke in the house? Yeah, he's coming up. Let's put our hands together. So he's a clinical and radiation oncologist committed to expanding equitable cancer care in Kenya. He led the establishment of the Cancer Center at Samburu County Teaching and Referral Hospital, pioneering access to oncology services for pastoralist communities in northern Kenya. His clinical focus includes head and neck, gastrointestinal, and urogenital malignancies, where he delivers patient-centered multidisciplinary care using advanced radiotherapy and systemic therapies. Dr. Mogaka actively engages in early detection, awareness, and outreach efforts targeting underserved population. He's a strong advocate for health equity, patient empowerment, and cancer education. Thank you very much indeed, Dr. Duke. We're also going to have Dr. Gavin Orangi. He's a clinical pharmacy specialist and serves as a county oncologist coordinator for Makueni County. Do we have Dr. Gavin in the house? Yeah, there he's coming up on stage. Let's put our hands together for Dr. Gavin. Dr. Gavin oversees the implementation of a county-wide cancer care program that spans prevention, screening, treatment, palliative care, and referrals across over 240 public facilities. His leadership has been pivotal in expanding oncology access in rural Kenya. At the national level, he is a member of the Treatment Technical Working Group under the Kenya's National Cancer Control Strategic Plan. Dr. Orangi also champions digital health innovations, having successfully led the deployment of the Empowered Digital Platform to enhance cancer screening, referral coordination, and data-driven making in Makueni County. We also have Dr. Hafsa Wanja. Do you have Dr. Hafsa, please come up on stage? Thank you very much. Let's put our hands together for Dr. Hafsa. She is a dedicated clinical radiation oncologist serving at Garissa County Referral Hospital, where she provides comprehensive cancer care to underserved populations in northern Kenya. She is deeply committed to delivering patient-centered oncology grounded in evidence-based medicine and the highest standards of clinical practice. Dr. Wanja emphasizes the integration of palliative care throughout the cancer continuum to enhance both survival and quality of life. Her practice combines compassion with clinical excellence, ensuring that patients in resource-limited setting timely diagnosis, appropriate treatment, and holistic support. And finally, we have Dr. Patrick Mutheni. Yeah, let's put our hands together for Dr. Patrick. Head of Oncology Pharmacy Services at Pangisile. How do you pronounce even this word? Pangisile Mtali. Is it a South African? Is it a Zulu? Yeah. He's the head of Oncology Services at Pangisile Mtali. I hope I got it right. Cancer Center in Kitui County. How do you have such a name in Kitui County? I mean, you need to guide us on this. Just creativity of the highest level. And Dr. Patrick Mutheni is a clinical pharmacist and head of Oncology Pharmacy Services at that name I have just mentioned, Cancer Center in Kitui County. He holds a Bachelor of Pharmacy and a Master of Pharmacy in Clinical Pharmacy with specialization in oncology from the University of Nairobi. Dr. Mutheni's work is dedicated to optimizing chemotherapy protocols, strengthening pharmacovigilance. Oh God, they have big names here. Systems expanding access to cancer treatment and advancing oncology research. He plays a pivotal role in improving the safety, quality, effectiveness of cancer care in Kenya's devolved healthcare system. Ladies and gentlemen, let's put our hands together for the team as we welcome oh, yeah, one more doctor. I think I was excited by the big names here. And so we have Dr. Fahad Abdallah Yassin. Yeah, there he comes. And as he come over, he's a physician and head of internal medicine at Lodwar County Referral Hospital. This is in Turkana County. He's a board-certified internal medicine physician and the head of the internal medicine department at Lodwar County Referral Hospital in Turkana County. He earned his medical degree from Ankara University in Turkey and completed his residency in internal medicine at Gazi University, also in Turkey. Driven by a strong commitment to played a pivotal role as a founding member and planner in the establishment of the Lodwar County Hospital Cancer Clinic, which is one of the first such initiatives in Kenya, underserved northern region. The clinic initiative, in partnership with the National Cancer Institute of Kenya, has significantly expanded access to cancer care services in Turkana County. Dr. Yassin remains dedicated to improving patient outcomes in marginalized communities while also enjoying football and family beyond clinical settings. So he's not just a doctor, he's a family man, and he loves football. Thank you very much indeed. Let's Chair, please take off.
Okay. Good morning, our distinguished guests. Thank you very much. And I'll be the chair of this session. My name is Dr. Irene Michoki, the County Chief Officer of Medical Services in Nairobi County. And I'm here with a team of experts. And we're going to explore on county-led models and investments that enhance equitable cancer care models in Kenya. And we're looking at in the context of devolution. And with me, you've been introduced to the entire panel of experts in cancer care, and we call them oncologists. So we're going to look at how Kenya's devolved health system is shaping inclusive, resilient, and scalable models for cancer care. And we're drawing from diverse county experiences, and the panelists will share practical innovations, investment pathways, and systems reforms that have expanded to, access to oncology services in both well-resourced and underserved regions. And the session will highlight the role of National Cancer Care Institute, Kenya, in supporting local capacity building, addressing persistent challenges in low-resource settings, and also identify collaborative solutions for integrated county-led cancer control. As we all know that health is devolved, and we've devolved practically the entire spectrum of services. Also, the dialogue will emphasize on the importance of sustained coordination between counties, the Council of Governors, and also the National Cancer Institute, Kenya, to institutionalize equitable cancer care across the country. So I'll open now the session to our panelists so that we start the session. And this is our leading question. So, what is one county-led innovation or best practice that has significantly improved access, equity, or quality in cancer care, and what makes it scalable across Kenya? So, you can, any one of us can start. Yes.
So good morning. Africans are told when you get the mic, you need to blow it twice, then tap on it to make sure that it's working. Anyway, it's not an innovation, it's something that is out there. So I'll speak on behalf of Makueni County. I coordinate cancer services within Makueni County. Let me see how I'll do this. So our innovation is actually literally around this room, and I'd like to thank the National Cancer Institute, Kenya, in regards to that, and it will form part of what we were discussing from the previous presentation. I think around, when you see around the drapes, the ones which have the Kenyan theme flag. There's a QR code, and I don't know if our cameraman can, I don't know, probably zoom in there so that everybody can be able to get that. It would really help. There is one in front here, I think. If you can get it on the screen, I think that would be great. Good. So if you take your phone and screen that, part of the innovations that we have done in Makueni and part of what was launched here was the Empower platform that Dr. Melio was talking about. And if, by your permission, I think probably I can talk more about this. Thank you. So if you screen that, part of what you'll do is it will guide you in regards to how can you be able to do a self-assessment in terms of screening. So the National Cancer Institute, in conjunction with the Savannah Informatics and I think Roche, came up with a screening tool that we could use in terms of community-based screening. So this can actually be done from your own level. So it can be done in form of either a self-assessment, and also probably you can go to the next step where it can actually be done from the facility. So it is a tool that probably is an innovation that I would call simple. Simple in regards that it is something that you can do on your own, can tell you your risk stratification. Are you low risk, medium risk, high risk in these regards? From a management point of view, whereby you have your oncologists, your county coordinators, and the people who actually make decisions in regards to matters cancer, it is actually something that they can view. Probably they can see and know in, I know there was a cervical survivor who mentioned something about Embakasi East. What is the prevalence of cervical cancer? Or how many women have been screened for cervical cancer in Embakasi East? The other thing that is actually good is I think you can actually scale it up. It's something that you can use not only for the female cancers of cervical and breast, which I think are the majority that we are using, but it has also been piloted for prostate cancer within our county. And we did more of a pilot of the same. I think we did for 3,621 there, people for both cervical, breast, and prostate cancer. And we have data in regards to the same. I hope you have scanned the QR code, and if you have, probably take the assessment, see your risk certification, and probably use that, because it's something that you can also use to assess yourself and find out, do I need to go ahead to a health facility or not in this regards. Thank you. Oh, the other thing that I need to point out, this is also very important, is the linkage. So through the tool, you are actually able, so as a healthcare provider, you are able to know person X was screened, was linked to diagnosis. One of our biggest problems that we have is we screen, for example, 10,000 people, and we give very nice numbers, 10,000. That is what the number speaks. Of those 10,000, let's say 1,000 or 10% had suspicious lesions or a lump, thinking arbitrary. But we don't follow up on this 1,000 to find out, did they reach to a healthcare facility? So the tool can guide you, can help you follow up on that patient, call that patient, find out what was the problem. Was it a financial constraint? Was it a healthcare issue? Because probably they went to the facility, but the facility was not able to do, let's say, a mammogram, was not able to probably do a PSA, was not able to refer the patient for radiological imaging or for a clinician who is not even in that facility. So these are the kind of things that you can do, report. And this is the kind of data that if it goes to the National Cancer Institute, can help scale this up to, get more data and find out the barriers that we have in terms of accessing for screening. That was a long monologue, but I hope it was useful. Thank you.
Thank you so much, Daktari. Do you have any other innovation?
Thank you for this opportunity, and I also want to acknowledge the efforts that NCI and the national government have placed to support our region. So for Garissa County, one of the best practices that we've initiated is the early integration of palliative care services into oncology care. So for the past 3 to 4 months, we've been able to review all new patients before they are seen by the oncologist to be reviewed by the palliative care nurses. And I'd like to mention that with the permission of the CEO, that the NCI, in collaboration with the American Cancer Society, are trying to introduce a navigation program into the different counties. So for us, as we are collaborating with them, we are leveraging on the palliative care services in terms of task shifting to be able to assist our patients from the time that they are diagnosed to the time their transit into survivorship, to be able to holistically manage them. So I think this has been proven by data that by initiating patients on palliative care at the onset of diagnosis improves outcome and also save costs in terms of the health system. So thank you.
Oh, that's wonderful. So you also you have an innovation? Carry on, Dr.
Yes, thank you. Thank you for this opportunity. My name again is Patrick from the Fangicilium Shirley Cancer Center in Kitui County Referral Hospital. It's a unique name, but it's named after one of the pioneers who fundraised for the Cancer Center through our strategic partner, the Catholic Medical Missions Board, internationally, now locally known as the Center for Medical Mobilization Board. Now, one of the strength of our cancer services in Kitui County, we are relatively 2 years in offering cancer services, lies on partnerships. Since 2017, we started the very first program, which is establishing the first county-based cancer registry. And this cancer registry was able to inform us, do we have cancer cases existing in the county, before we go into the infrastructural investment. And this cancer registry gave us data that informed the very first program that came back to us in between 2022 to 2025, which was the palliative care cancer program, again supported by the county government and the strategic partner, the Catholic Medical Missions Board. Now, from that, having the partner on board and the county, we were able to see if we give palliative care, are we going to be optimal in cancer services? If we offer cancer services, are we going to be optimal? And we started the first part of the program, which was palliative care, started psychosocial support groups, which have now formed CBOs. And these psychosocial support groups were supported in different ways, including getting cash transfer programs, which were supporting them to go for treatment. And by the year 2023, again in the same partnership, and with the great support that we got from the National Cancer Institute, again thanks to the National Cancer Institute, we established the first county cancer center. Whether privately or publicly, this is the first cancer center in the county. And this cancer center, through that innovation of starting from data, palliative care, and then cancer treatment, we have been able to see around 4,500 patients on either new or revisit basis, and have been able to initiate up to 218 patients on at least one cycle of chemotherapy within that 2 years. So for us, that is something we have to we celebrate as an innovation that county came from data all the way to treatment. Thank you.
Thank you very much. Dr.
Thank you very much for this opportunity. I represent Nakuru County Hospital, and I think the innovation that we had was starting with what we had. I think most people think they have to have a building that is labeled a cancer center. They have to have the space for it. So I remember the innovation we had a civil servants clinic, and we were allocated one room for a consultation room, one room for triage, and then we had one room that was large that was used as our chemo administration. When we began, in the interest of using what we had, we started mixing chemotherapy in an incubator. It's not the best, but there was a need. And I think what Nakuru was able to do was show interest, document, and have the gold that is data. So I think if everybody conceptualizes the space that is existent, it is very possible to have a cancer center. And starting was difficult, but we had very good political goodwill, which is also very important, to make sure the decision makers understand why cancer is important, understand what are the numbers. And I think as healthcare professionals, sometimes we do not see the value of numbers. We focus on the treatment, but really presenting data to decision makers is what prompts decision to be done. So I think for Nakuru County, using what they had and really capitalizing on data was something very important in ensuring we are where we are today. So we had small beginnings, started with one consultant who was given a contract. She would come once a week, and she was very motivated in ensuring the services happened. We started with one oncology nurse, we had one medical officer, and another nurse who was a general nurse who was on job training. So from very humble beginnings, you can see where we have grown to where we are today, where we have chemotherapy seats, we have a very large hood, we have 2 machines for radiotherapy, we have brachytherapy. So really seeing the vision and starting with what we have can really push the agenda and bring big things. Thank you.
Thank you, Dr. And while we're at it, you've even briefly touched on the next question on how you started your oncology services at Nakuru, County Referral and Teaching Hospital. So in terms of infrastructure, what is it? What infrastructure or governance levers have enabled Nakuru to scale oncology services sustainably?
So like I mentioned, having the decision makers see the concept is very important, and as data. As we go along, there will be like presentation at the back. So that really shows our data. Nakuru is second to Nairobi in terms of the cancer incidence and treatment, and that was a research that was done just to show data is very important. It really helps you make decisions. We really started small. If you look at the next slide, you'll see that the data for the very first month when the opening happened, we opened in May, 24th May 2018, and you can see the political goodwill that was there. The governor was present, and that was our data initially. You can see for chemotherapy, the very first month, we had 15 cases and a total of 349 patients who came for services in our facility. That was in May. In October, which is the next slide, you'll see the growth. We had 783. And we really didn't have reporting tools, so we were just making an Excel sheet and submitting that information just to show the need that was there. From this data, we were able to also classify how many patients are we sending to Nairobi for radiotherapy. And the need was there because per week we would send around 15, and monthly maybe only 5 would go. The rest would not have the funds to go. And if you look at the next slide, you're able to see that we had a lot of partnerships. There was an organization that was led by Dorothy Nyong'o, Her Excellency, and our governor. So the governors also had taken a lot of initiative in cancer management. We started a support group that was initially inside the department. It grew to outside the department, and that really had a big impact because patients would meet patients who had been treated years ago, and it created a lot of hope and sustainability. We didn't just focus on just the treatment. We also arranged to have Zumba and also other psychological activities that help the patients not just focus on the disease. Practical support, we would ensure we would look for donors to give breast prosthesis, colostomy bags whenever they are available, just to help us not just focus on the disease, but actually focus on the patient, realizing that they are alive. So the data we collected in terms of the patients we would refer made the county really want to even have accommodation. So the county looked for a house and created accommodation for patients. So they would stay there for free. They would come with food and cook it there. There was an MOU with Kenyatta, but the waiting times were long, so we had an MOU with Nairobi Hospital, and they agreed to give us the rate like the government hospital. So our patients would be treated in Nairobi Hospital, but at the rate of Kenyatta, and that was really good for patients because their waiting time was reduced. And because of that data, if you look at the next slide, you see now the plans on radiotherapy began, the construction began, there were visits, we would see our governor in our department like every time, and finally we launched the radiotherapy center. Currently we have 2 machines that are active, 2 radiotherapy machines. We have 1 brachytherapy machine, and as you can see, a lot of work is going on in the department, and that ensures that patients are getting services. Yes, we have challenges, the machines sometimes break down, but our planning team is excellent, it does a good job, and we are hoping to continue having good services. NCI and the National Cancer Institute have really helped us. They have really made sure that we have support. They are really instrumental in ensuring even the second machine was launched when we had a challenge with the first machine. They were with us even last week on Friday, just before the summit, and we are really grateful to that. We've also had support from the Ministry of Health. The NCCP has been there for us, ensuring we're involved in the decision making, like the protocols that have been made, and it's really gone a long way to ensuring we have holistic care in Nakuru County.
Oh, that's wonderful. And so far in these discussions, what's coming out is the role of partnerships in health. And perhaps I should propose that WHO should actually include another pillar of health, partnerships. And Dr. Mel, you're doing very well. I'm proud of you. And now let's go to Makueni, Dr. Orangi. Tell us, what approaches has Makueni adapted to improve access to cancer medicines and manage stock reliability? And while you're at it, you can probably combine with this that how can county-level procurement systems be strengthened to ensure consistent oncology medicine supply? We're looking at the supply chain of cancer medicines. Thank you.
Thank you. So, one of the biggest challenges that we have in regards to cancer commodities and actually medicines is actually the stockouts or the lack of cancer commodities. They are either stocked out in our national stores, that is the KEMSA, and that is actually a very big barrier in regards to accessibility of these commodities, both for the facility and also for the patient, which actually now spills over. I think the biggest thing that we can actually do from our end, and especially at a facility level, is first to make sure that there is allocation of these funds towards oncology. For most of the facilities that we have, what we would call the regional cancer centers, we do not have a specific budget line for cancer. Cancer is one of those, and I'd call it that, relatively new kids on the block, but you still need to see these patients and provide accessibility to them. So having a ring-fenced revolving fund would actually help in regards to making sure that these commodities are actually available. And when I was talking about commodities, I tend to, enlarge in that scope, not just the drugs. You also need to talk about the screening commodities, because you're talking about probably your HPV DNA kits, you're talking about your breast prosthesis, colostomy bags, and all that. So that fund needs to be ring-fenced so that whatever is used from the facility or from the department is still plowed back to the department. Think about it this way: if SHA is providing this money from my end, and this is what we were actually doing from the county government, it is some form of external revenue for the county, because you're getting services and you're getting payment from SHA for these services. So it's actually a form of revenue that is coming to the county. And if this money is ring-fenced to be used to improve whatever you have, I think that it will be great. That can be done for both the county funds and also what we call the FIFs for the facilities that have the facility improvement funds. How do we ensure that there is stock reliability? Now that comes down to things like forecasting. We need to have a way of, projecting and finding out how much of a certain drug do we need in Kenya. It is I think by now we are able to know of our breast cancer patients, how many are HER2 positive, and of these, how many of them are actually eligible to get a drug like, let's say, trastuzumab. So we can actually forecast, and I think there's something called a consumption method, and see how much we need for a 1-year period, a 5-year period, and if that can be done and also costed and put in the midterm, and actually suggest for that to be in the midterm National Cancer Strategic Plan, so that moving forward we know how much we need to budget in terms of the cancer drugs. I think that would be great.
Thank you very much. You can see the way we are moving across the counties. We are all seated here, but we are traveling across the counties. So now we take off to Garissa County. Dr. Hafsa, what are the targeted solutions that are needed to sustainably deliver oncology services in arid and semi-arid areas? There are some regions like Garissa, and also you can combine with, what community-based or outreach approaches have proven effective for cancer awareness and early detection in low-resource settings.
Okay, thank you for the questions. To start off with the first, I think for sustainability, partnerships. As you've mentioned that we're in a low resource setting. I'll just give an example of what Garissa is doing right now. We are leveraging on the different skill sets from the different counties. For example, we work in tandem with Kitui. We support them in terms of radiotherapy services, as well as the Isiolo counties and the neighboring counties. And so what we've been able to do is collaborate with the different specialists in the different counties with the aim of trying to reduce the treatment time, or rather the time our patients are initiated on treatment. So with close collaboration and partnership, I think is a way to go in terms of trying to be cost effective and also to be efficient. The other way, or the way to go, is to be culturally sensitive, because we need to get the community feedback to be able to know how best we can be able to address the oncology, the endemicity of oncology in our countries, and to be able to get feedback as well as also sustained output. In terms of community, the second question, where we're looking at the community-based or outreach approaches, one thing that has worked for our community or for our county is community engagement from the onset. I'll give an example in terms of the HPV vaccine. So when we were rolling out the HPV vaccine in our county, what we did was to bring the parents on board. So when a child was to be vaccinated, we first had a sitting with the parents or the guardians and did health education, told them why are we vaccinating these girls and the benefits. And I remember one of the questions that was coming up was, why are we targeting the girls and not the women? Because when we are presenting our case, we are presenting women as suffering from cervical cancer. So we were able to negotiate with them, and our women were the champions, bringing their children to different sites for vaccination. So I will insist, grassroots involvement is the success of our initiative. Thank you.
Thank you for that. So we're looking at buying strategies and also sharing resources. Also, perhaps we can throw in, perhaps think about telemedicine, right? In fact, that way we are able to share all the resources we have as a country just by accessing all the experts that we have. You may find one county has more experts in a certain area, and like look at oncology, we even have sub-specializations. So if you can invest in such a thing, that would be good through partnerships. Like I said, it should be the next pillar, the 8th pillar in health. Okay, thank you very much, Daktari. So, and now we are off to Turkana County. Okay, Dr. Abdallah, kindly tell us, and how has the National Cancer Institute Kenya support shaped the development of cancer services in Lodwar, and what further technical input is needed? You can answer that for us.
Thank you very much for the question. First of all, I'll start by thanking NCA Kenya for giving us this platform. So this is a platform that we've been honored to be in this platform, and it shows the marginalized communities are no longer marginalized. We have a voice. We are being given the platform to have a voice in the national platforms. So NCA Kenya have been collaborating with Turkana County since the beginning of this year. One of the first engagements we had with them is through the honor of holding the World Cancer Day 2025 during this year. It was quite a good engagement. It created too much awareness to the community, because the biggest challenge we have in these marginalized communities, it is the belief that most of these diseases are cursed, or it is a disease which is someone has put some witchcraft on them or something. So this engagement with NCI and the hosting of the World Cancer Day has really created awareness and knowledge exchange. The second thing we did for the first time in the history of Turkana County, we were able to administer chemotherapy to 6 patients. Through the leadership of participations of Dr. Meli and Dr. Joan from MTRH. They combined a team of MTRH, LCRH, the Lodwar County Referral Hospital, that is, and the NCI Kenya team. We were able to give chemotherapy to 6 patients. The other engagement we also had with them, immediately after the World Cancer Day, we held a meeting with the leadership of also, again, Dr. Meli, the management of Lodwar County Referral Hospital, the team from MTRH, whereby we formed a steering committee, whereby within the shortest period possible, we will see the actualization of a comprehensive cancer center, so that we give more service delivery in terms of matters cancer to patients within Turkana County. Also, NCI Kenya they have been continuing supporting us in terms of, we had a 5-day training whereby they took a part of the oncology team to MTRH, whereby we did an observership training program, and also we saw the operationalization of a cancer unit within a comprehensive cancer center. So in the future, we are requesting all stakeholders, the NCA Kenya, and all health workers. For example, like in Turkana County, it is the second time we are advertising a position for an oncologist, but no one has availed themselves to come visit us for engagements. So we are also requesting the oncologist in the house to try to come and work with us to give this service to our communities back in the rural areas. Thank you so much.
Oh, thank you, Dr. I think you've delved into the next question I was going to ask about service delivery. Or perhaps you can expound more.
Service delivery, one of the things that we've seen that has really contributed in service delivery within Turkana County is an individual championship, which during the opening of this summit, we all acknowledged that our sister, Ms. Suleka Aden, was awarded a recognition for championing cancer care within the most remotest county in Kenya. And she has been stewarding this journey. She came up with an initiative whereby she formed the Turkana support group, cancer support group, with several individuals within Turkana who have been creating awareness. They have been collaborating with many local and national partners so that we improve the service delivery within Turkana County.
Okay, thank you very much, Dr. And now we're off to Samburu County, and we have Dr. Duke Mogaka. Kindly tell us, Dr. In what ways has NCI Kenya engagement accelerated Samburu's oncology capacity, and how can this be expanded?
Good morning, everyone. So I come from the Butterfly County, Samburu County, and it's interesting to note that we are discussing at the national platform all the advancements and the ideal practice that we should be having on the oncology spectrum of care, but you have areas that are really underserved and do not have the basic access to care. So first of all, were it not for NCI, under the stewardship of Dr. Meli, I'd probably not be here to discuss this, but then the population that is underserved in the ASAL counties is suffering from, first of all, it's like they are overlooked as a population that probably doesn't even have oncology or even cancer cases. But then what NCI did, they literally jump-started the discussion when it comes to oncology care in Samburu County by bulldozing with the whole force of government that landed in Samburu County and made now the leadership to listen, that they have an oncologist. I was actually launched as the oncologist in Samburu County. And what that did, it triggered the discussion that, yes, this is a service that needs to be offered to the people. And we had a whole week of oncology cancer screening where we had over 300 people screened, and that converted to the linkage to the National Oncology Reference Lab. So pathology services were sorted in that regard. And on top of that, we had a good donation that kickstarted us giving the first chemo and hormonal treatment in Samburu County, and that was really a big deal. And thank you very much to Dr. Meli for really kickstarting this initiative. So what this did then, now moving forward, is we had a robust discussion with the county government in terms of we're setting up the oncology clinic. You know, it sounds like a really small deal right now in listening to my colleagues that you're talking about a unit and a radiotherapy machine, and yet a clinic is such a big deal in an area like Samburu County. So we've had patients now coming in, patients under care who are traveling all the way to Nakuru. I want you to imagine that Samburu County goes all the way to Baragoi. You can understand, like, Baragoi is quite far, and you know, it's one of those ASAL areas that is mad with banditry and all kinds of, you know, people not be able to achieving the quality of care that is deserved, moving all the way to Nakuru and even Nairobi to try and get this access to basic care. So moving forward, we're still in partnership with the NCI, and you know, in terms of the ball is rolling towards us actualizing an oncology unit, whereby we can have now our patients in-house getting our chemotherapy or the whole spectrum of care, from prevention strategies to screening and actually giving treatment, survivorship, and the follow-up. So yes, it is a big deal that NCI has really triggered in us to start off these services. Thank you.
Oh, that's very good. And while we're at it, what are the systemic barriers that remain for counties like Samburu in accessing national oncology support platforms?
As I had said earlier, I think the first time I went to Samburu County as a medical officer, I went back because the geographical limitations and access to just the county itself was quite a big challenge. And this now, if I were to look at it on the oncology spectrum of care, where you want to start off from your prevention strategies, screening, treatment, all this cannot be actualized as you would in a setting like Nairobi County, because you know, the county is torn between the balance of whether to take you know, a mobile unit or the services to the people, or giving water or food as the priority. So first thing was that, the geographical limitations. On top of that, the human resource aspect. I'm the only oncologist or the specialist in oncology with 2 nurses as the only now when it comes to cancer care. With this, we try as much as possible to traverse the county, but then we need more people to train an oncology pharmacist. We need a CEO at least to try and support that, because it's a really extensive county. And on top of that, the socioeconomic factors, the resources are more pulled towards offering basic services, basic needs, that is food, water, shelter, rather than giving the health its priority that it deserves. So I love the fact that we are actually having this engagement and this discussion, and probably with the support of NCI further, that we can also have even this to be embodied into the Empower Clinic program, so that we can also diversify the access to basic screening, basic prevention strategies, and this would go a long way in helping us now get the equitable access to care. Because it's interesting that we are in Nairobi and discussing all these novel ideas, and there's a similar patient in Samburu County who cannot be able to access these services. Yeah, and we're in the same country.
Thank you, Daktari. And now we're off to Kitui as we come close, we're getting to the end of this. So, Daktari, Patrick, so what county level policies or investments have helped grow oncology pharmacy services in Kitui? And also, and how can counties standardize pharmacovigilance and quality assurance in cancer drug management? You can answer those together.
Okay, thank you. So, part of the investments that the county has done to ensure that there is sustained availability of commodities is rallying on the Finance Act. That's one thing I usually celebrate the government for. The Finance Act tries to talk about, specifically the FIF Act, talks about the user fee, the money that is collected at the facility, especially government, being used at that facility. We have struggled over years to try to fight for our facilities, at least to use that fund to be able to sustain the health products and technologies, as well as the workforce and any other expenditure within the facility. And thanks to the government of the day in the county, beginning this year, we have been allowed to spend the money that is collected in the facility, and that involves us being in the oncology space, fighting for our allocation. Whatever we generate must come back to buy the commodities for the patients. So that's one area that we celebrate. The second one is ensuring that our oncology budget is captured in the county HPT expenditure. So anytime we are generating expenditure for the health products and technologies, oncology is listed as an independent line, such that we know there is an investment for oncology products. I also mentioned about partnerships. We have had partners coming on board to help us with screening commodities, diagnostic commodities, and even for some equipments that are very key. And this is an area that if counties can also strengthen the partnerships that are existing. I started by mentioning our relationship with the Center for Medical Mobilization Board, which extended to involving the Bugando Medical Center, which is Tanzania, and we also have the University of KwaZulu-Natal in South Africa. All these are informing what we practice in Kitui through research, through support in terms of some of these commodities, and it's an area that some of us can try to look into. Then the last thing is about pharmacovigilance. First is to appreciate NCI. For the first time I saw in the last 2 months, we had pharmacovigilance discussions with all oncology practitioners, which is something that has never happened in the oncology space. And we celebrated that so much. Pharmacovigilance is about monitoring the products that are coming into our market. What is it that is new that is presenting? what is that is not necessarily new, was reported in the clinical trial, but is presenting uniquely in our populations. And yesterday, I think Professor Abinya mentioned that the patient is coming to the facility not because they know someone, but because they have faith in the system. The patients who come to our cancer centers have faith in us as the healthcare practitioners, have faith in the industry that is manufacturing the drugs. We saw the most recent studies that were, I think was published in the BMC, showing that in low and middle income countries, 1 in 6 cancer drugs is substandard. So that raised a lot of alarms, and everyone was asking themselves, what is not happening? Why is it that in the most vulnerable population, then we have substandard drugs? So this calls us to be vigilant, whether as patients, as healthcare workers. I tend to believe in 2 statements. One, there are 2 people that will determine whether you are giving water or a drug to the patient, or a placebo for a better term. That is the manufacturer. Are you ethical enough in what you are releasing to the market? Number 2, I as a pharmacist, in my compounding chamber, am I giving the drug to the patient, or there is something else I'm giving? And finally, to any other healthcare provider who is handling the product outside the compounding room, including the patient going home. That is where now pharmacovigilance comes in. So we need to be alert. Anything that we suspect does not meet the standards needs to be reported. And we have pharmacovigilance reporting system with the Pharmacy and Poisons Board, where we need to report all these things, including, I give an example. Just the other day I was handling some products that were shipped to us. And from the visual inspection, I could see the drug had already spilled on the package. This is not just any other drug, because it's already toxic, it's carcinogenic for me and anybody, a person who is handling it. So it was my responsibility to sit down and report, this is already substandard according to me. So the board has to take over, of which it has been doing that. It does not only happen for drugs. Sometimes we even have non-pharmaceuticals that we are handling in the same units. And I give again another example. I got some sterile gloves, not sterile, nitrile gloves. The packaging of the gloves, when you get it, after wearing it, even before you go to the chamber, the glove is torn. First, second, by the time you are doing the third one, you're already bored. So that's part of the quality that we need to keep monitoring as healthcare practitioners, as patients. When you go home with a drug as a patient, is there anything that you have not been told about and you have detected or you have experienced? Then we report through the PFALs, or as the PPB reporting system. Then the last one is about consuming the data. Probably in the next NCI summit, we need to hear some scientific presentations like what has just been presented by Kemri here, trying to tell us, I know NCI is doing a lot, again, in a new way that is not being done by any other program, sponsoring research, because we are getting research grants under cancer care. Probably in the next summit, we'll have some people presenting their findings in those researches. And one of the areas that probably we request, and here I am being biased, maybe you will sponsor us to do a study on the quality of the products that we have as cancer care providers, so that we appreciate whether what we are getting is foreign data or is our own data. So we have to strengthen the data that we have, consume the data, and finally try and our level best, what we have started to invest in pharmacovigilance CMEs, we continue even in our facilities. Thank you.
Wow. Thank you so much, Daktari, for that informative, your shot. Thank you. So, as a parting shot, so what one joint action should counties, the Council of Governors and NCI prioritize over the next 12 months to institutionalize decentralized cancer care across Kenya? What do you think, as a parting shot? We can start with you, Daktari.
Thank you very much again. Mine will be, we have talked about access to medicines. And our biggest distributor of commodities is KEMSA in public setting. So we are asking NCI, the Council of Governors, the Ministry of Health, to try to empower our KEMSA at least to stock, even if not 100%, 50% of oncology products. If we start there in the next 12 years, 12 months, probably by the time we are coming back here, we'll have addressed many of our health products and technologies challenges in oncology. Because I mentioned yesterday in one of the meetings, we just did an order last week, and out of all the commodities available, there are only 2 products for oncology, out of a list of 300 plus, which is painful, considering that as government, we need to first do government-to-government purchasing, G2G. So it means that all the money have been allocated under oncology and only buy 2 drugs. Thank you.
Thank you. Let's go to Garissa, Dr. Hafsa.
So I want to appreciate all the effort by the national government, by the NCI, by the county governments. So for me, I'll just say let's sustain this communication. Let's maintain it and have a positive outlook. So thank you.
Thank you so much. We're off to Makueni.
We are traveling.
We're still traveling. The drone is still on.
Yeah. We have a problem in Kenya. We are fighting a war using probably, I would say, crude weapons. If most of our patients are at stage 3, stage 4, that's something that we need to, change the narrative in regards to the same. So the one parting shot that probably have is we need to, have a shift in mindset, see how we can invert that pyramid so that we have more of stage 1, stage 2 presentation rather than late stage, which is stage 3 and stage 4. And primarily the main ways that probably this can be done through the Council of Governors, NCI, the Ministry of Health and other partners will be, we need to do a lot in regards to what Dr. Umo Luga and I think Dr. Bor JP mentioned in terms of prevention, either primary or secondary. We need to do more in terms of advocacy for lifestyle changes. We need to do a one government approach. We have environmental carcinogens out there. I mean, you live well and all that, but you are still under risk and you are exposed. So these are the kind of things that we need to look at. We need to do early screening, low-lying fruits. We have the vaccine. Why are we not reaching at least our targets? We have our 90-70-90 targets. Why are we not there? We have our schools, whereby if tomorrow we hear there is a measles campaign or a polio campaign, sometimes some places report even over 100%. Why are we not able to reach 50% for HPV? So we need to change our mindset and the narrative in terms of prevention, primary and secondary prevention. Thank you.
Thank you, Dr. The drone is off to Samburu.
Yeah, for me, I think being among the youngest oncology clinics, for me I would say dealing with county governments whose priorities are skewed towards what for them will be more beneficial. I think if you can have a discussion around having a framework or a joint collaboration in designing what a center of excellence, like a county oncology center of excellence would look like from all the stakeholders, led by NCI, and now looping in the Ministry of Health and the county governments, would go a long way in now aligning the resources now from the perspective of the centers or the clinics or the counties that do not have that framework, to align the resources now in terms of achieving a county center of excellence or an oncology center of excellence, like for example Nakuru. This will go a long way now starting this discussion at the county level, or with the, when you sit down, when the budgets are being appropriated, we can now say this is where we want to go, because we already have a framework that we can follow. So basically, having a structure that cuts across all counties and can be scaled up now from the grassroots, that is like from Samburu County, would be a good step in the right direction in terms of coming up with centers of excellence that can offer equitable access to oncology care. Thanks.
Thank you, Dr. We are off to Nakuru. Dr. Wanda?
So I think starting somewhere is something that should happen. We need to start where we are. We might wait for too long before we have the state of the art, but there are patients as of now. So we need to start interventions, one. Two, the facilities need to really see data as gold. Three, we need to have partnerships that are robust. I remember when we started the clinic, we had trainings by Anne Coril and Gladys Chesumbai on cancer registry. That time the clinic had just begun. It was a few months. But they saw the vision. They saw where we could go. And I think that training really helped us really guard our data. And that training is the reason I think we are here today. So also having partnerships and believing in centers at the beginning, like now where Samburu is, believing in them and training them so that that data can be able to be assisted. The other thing at the COG and NCI level is thinking about the oncology workforce. Where are they? And how can we redistribute them to support the regional cancer centers? So that if we have a clinical oncologist or a radiation oncologist in a county that is referring patients maybe to Nakuru, is there a way that the counties can agree to have percentage time where that oncologist can work in the center? So that we boost numbers, it will reduce the treatment time, the waiting time will go low, and since they are already referring patients to our center, we would have a very large team. And I think at that level, that discussion needs to be had. We have colleagues in places without centers, but they can really support the regional centers and ensure radiotherapy services, chemotherapy services are really excellently done. Thank you.
And finally, to Turkana County, Dr. Fahad.
Thank you very much. Mine will be maybe to add on in terms of how we can be able to empower resource. So we are seeing an extension of the scope of cancer within these many counties within Kenya. So this scope, I think, should also match with the human resource, so that we know that the key player in this course is the human resource. So I call upon the county governments, council of governors, to see a way whereby they can come up with a plan in addressing the human resource, so that going forward we get Afya Bora instead of Bora Afya. Thank you so much.
Oh, that's good. Thank you so much. And let me also contribute and give my parting shot on this. So, first of all, the discussions were so amazing. There's a lot personally I've learned, even as the Chief Officer of Medical Services here, that we can leverage on. But besides that, there's so many opportunities, partnerships. It's come out clearly that we really need to partner in this space so that we're able to fulfill and offer good quality services. Just good quality cancer care. Also, we leverage on technologies. I just mentioned about telemedicine. It's something that we are looking, we have telemedicine in Nairobi in one of our facilities. So we're looking at leveraging on that and maybe other technologies just to offer cancer care. Again, HPTs, the health products and technologies, I'm looking at access programs. That's something we can leverage on, access with our partners. There's a lot of, drugs that are formulated. How can we put some of our patients on such programs, access programs? And again, we're looking at quality of drugs. That involves a lot of research and clinical trials, which is an area that I'm very passionate about, clinical trials. Also, it's come out that we need to invest in human resources for health. Cancer specialists are not very many, but we can look at sharing what we have as a country. Again, increasing budgetary allocations, political goodwill, that is one of the main drivers of decision making and even pooling resources in this country. So in terms of cancer care, that is something that we need to actually push for with our political class, our MCAs, our MPs, in terms of legislation, even for monies, for ring fencing and all that. So that is something we need to look at and push hard, lobby. Again, robust promotive and preventive measures in terms of screening, for example, and increasing advocacy and awareness. We've talked about data use to make informed decisions. So that is our liquid gold, like Dr. Riwanda has said. And also health research. In Nairobi, a push for health research, and at this point, I'd like to mention that we're having our second health scientific conference in November for Nairobi County, that is actually county-led. So this is a good platform also, just to share knowledge, just like this summit as well. So, and you're all welcome. And finally, that yes, cancer is a scourge that we all need to get involved in. And it's not just about the technical persons, even the non-technical, our politicians. Like I said, decision making in this country is actually mostly political, based. So we need to lobby and push our politicians to be able to see our vision and see how to help us out. So with those few remarks, this brings me to the end of this session. I don't know whether we have, Mashima can probably guide us. Do you have a few minutes for questions?
Unfortunately, we do not.
I know it was intensive, thank you.
But it was very engaging. I think one thing that we have all learned is that when counties are resourced, when they are empowered and they are supported, they can be agents of change in cancer care. Asante sana, Dr. Mushoki, for leading such an engaging conversation. You can take your seats.
Thank you so much.
Tuwapigie makofi. And as they take their seats, I would like to also call the members who participated in the first session, led by Dr. Visva Pillay, to please come here and receive their gift packs. And I'd also like to recognize the presence of the Governor of Kisumu, Professor Anyang' Nyong'o, and the First Lady of Kisumu County, Mama Dorothy Nyong'o. Karibuni sana. And as they receive their gift packs, we're about to take tea, but there's a short presentation, I think, O'Brien, a short presentation that we'll have. There's something that the King of Condoms left out yesterday. And I think O'Brien is better placed to do this than I am. I think he has a better sense of humor than I do. Wow. Please go ahead.
Yeah, so you realize that yesterday the circle was not complete because the Queen was missing. So the good news is that we have the Queen, and she's going to be accompanied by the King, who is in the house with us. So they'll be taking us through another session that will take about 10 minutes, okay? And then, but before we do that, we're going to have a poem by so the poem will come during the closing ceremony. So the lady with the poem, you need to be on standby. For now, this is what we are going to do so that we can manage time properly and ensure that we break for lunch at exactly the desired time. Tea is ready together with the mandazi, okay? So that's the good news. They come as a package. But we also need to go and greet the great people who at the exhibition hall, okay? They're just in the ballroom 3. Just right next to us. So this is what we are going to do. Today we are not going to exit from those 2 doors. So we are going to go through this door, go to ballroom 3, say hello to the exhibitionists, okay? Then we come out, grab our teas and mandazi, and then we come in to continue listening to the king and queens of condoms. So this is how we're going to do it. The first 3 tables from here, okay, they're going to exit quickly, otherwise you're going to miss out on the presentation. You go, say hello to people there, go grab your coffee, grab your tea, grab your chai, and then you come in to listen to the presentation, all right? So if I were you, I'll be out by now, all right? As we do that, once we have that presentation by the king and the queen, now all of you, just as I speak, you can just come out. I talked about the first 3 tables because again we don't want to crowd out that place, and then we miss out. So just dash, take your tea, and then you come back.
The first 3 rows.
Yes.
Yes. At least you have the first 3 rows.
Mm-hmm. And then the other rows will be guided accordingly. Sawa sawa. All right. So meanwhile,
is the queen here?
What is the queen? You're always leaving your queen behind. Eh? All right. You want to do the presentation without the queen? Yes. But why can't we see the face of the queen? Or is it an imaginary queen? No. Yeah, so let him call the queen so that we confirm that, yes, it is indeed there is a queen of condoms. So, Mashirima, please pick it up as I organize the team. So you find me on the other end. Forgive me if I hurry you up to come in. I'm very good at doing that so that I allow you to learn, to listen, and of course to enjoy. Asante sana.
Cancer care is changing in Kenya. Empower 1.0 gave thousands access to early screening and treatment. Empower 2.0 takes it further, digitizing the journey for faster, smarter care.
As a country, we are determined to ensure that every Kenyan, regardless of where they live, can access quality, timely, and dignified care. In this case, specifically cancer care.
The Empower 2.0 program is going to focus on the successes of Empower 1.0, which is the integration of breast and cervical cancer in the primary healthcare system. The focus will also be to understand the patient journey from an end-to-end perspective, starting from awareness, screening, diagnosis, and to treatment.
We are able to do patient link-up, patient follow-up, and also patient follow-up in terms of management, and also post-management follow-up, helping us to reduce allowed times toward the follow-up and the treatment of this patient. As area, the way they have been doing, it's more manual registration, but nowadays when we're having this Empower, it's also enabling us to have that dashboard program whereby it can give us the entire detail of our patient, from their registration, the time they have been seen from the facility, the time they have been referred to the facility of investigation, and the facility that they are doing management.
Faster diagnosis, quicker treatment, real lives changed.
Over the past year, we've seen firsthand how digitization can accelerate impact. What began as a pilot in 20 facilities has now scaled to 76 sites, with 56 additional digital sites and 200,000 patients screened for breast, cervical, and prostate cancer.
Local evidence generation and data for decision making is critical towards advancing the future of cancer care. We have understood that digitization is important to align to the universal health agenda, and this milestone complements integration to the digital health superhighway. For that reason, the impact of Empower has demonstrated that the future of cancer prevention and control is digital-led.
The Empower program, which has provided for real-time data, is a great asset that enables our patients, our clients, to access care without loss to follow-up and improve outcomes. This progress has not been possible without working with all the stakeholders in this space, collaborators who have provided an opportunity to be innovative, and this has been enabled by working with private sector and other stakeholders. Our vision is very clear: to provide digital infrastructure that empowers counties, equips providers, and enables patients to navigate their cancer journey with confidence and support.
Cancer care is changing in Kenya. Empower 1.0 gave thousands access to early screening and treatment. Empower 2.0 takes it further, digitizing the journey for faster, smarter care.
As a country, we are determined to ensure that every Kenyan, regardless of where they live, can access quality, timely, and dignified care. In this case, specifically cancer care.
The Empower 2.0 program is going to focus on the successes of Empower 1.0, which is the integration of breast and cervical cancer in the primary healthcare system. The focus will also be to understand the patient journey from an end-to-end perspective, starting from awareness, screening, diagnosis, and to treatment.
We are able to do patient link-up, patient follow-up, and also patient follow-up in terms of management, and also post-management follow-up, helping us to reduce allowed times toward the follow-up and the treatment of this patient. As area, the way they have been doing, it's more manual registration, but nowadays when we're having this Empower, it's also enabling us to have that dashboard program whereby it can give us the entire detail of our patient, from their registration, the time they have been seen from the facility, the time they have been referred to the facility of investigation, and the facility that they are doing management.
Faster diagnosis, quicker treatment, real lives changed.
Over the past year, we've seen firsthand how digitization can accelerate impact. What began as a pilot in 20 facilities has now scaled to 76 sites, with 56 additional digital sites and 200,000 patients screened for breast, cervical, and prostate cancer.
Local evidence generation and data for decision making is critical towards advancing the future of cancer care. We have understood that digitization is important to align to the universal health agenda, and this milestone complements integration to the digital health superhighway. For that reason, the impact of Empower has demonstrated that the future of cancer prevention and control is digital-led.
The Empower program, which has provided for real-time data, is a great asset that enables our patients, our clients, to access care without loss to follow-up and improve outcomes. This progress has not been possible without working with all the stakeholders in this space, collaborators who have provided an opportunity to be innovative, and this has been enabled by working with private sector and other stakeholders. Our vision is very clear: to provide digital infrastructure that empowers counties, equips providers, and enables patients to navigate their cancer journey with confidence and support.
Cancer care is changing in Kenya. Empower 1.0 gave thousands access to early screening and treatment. Empower 2.0 takes it further, digitizing the journey for faster, smarter.
Country, we are determined to ensure that every Kenyan, regardless of where they live, can access quality, timely, and dignified care. In this case, specifically cancer care.
The Empower 2.0 program is going to focus on the successes of Empower 1.0, which is the integration of breast and cervical cancer in the primary healthcare system. The focus will also be to understand the patient journey from an end-to-end perspective, starting from awareness, screening, diagnosis, and to treatment.
We are able to do patient link-up, patient follow-up, and also patient follow-up in terms of management, and also post-management follow-up, helping us to reduce allowed times toward the follow-up and the treatment of this patient as area, the way they have been doing. It's more manual registration, but nowadays when we're having this Empower, it's also enabling us to have that dashboard program whereby it can give us the entire detail of our patient, from their registration, the time they have been seen from the facility, the time they have been referred to the facility of investigation, and the facility that they are doing management.
Faster diagnosis, quicker treatment, real lives changed.
Over the past year, we've seen firsthand how digitization can accelerate impact. What began as a pilot in 20 facilities has now scaled to 76 sites, with 56 additional digital sites and 200,000 patients screened for breast, cervical, and prostate cancer.
Local evidence generation and data for decision making is critical towards advancing the future of cancer care. We have understood that digitization is important to align to the universal health agenda, and this milestone complements integration to the digital health superhighway. For that reason, the impact of Empower has demonstrated that the future of cancer prevention and control is digital-led.
The Empower program, which has provided for real-time data, is a great asset that enables our patients, our clients, to access care without loss to follow-up and improve outcomes. This progress has not been possible without working with all the stakeholders in this space, collaborators who have provided an opportunity to be innovative, and this has been enabled by working with private sector and other stakeholders. Our vision is very clear: to provide digital infrastructure that empowers counties, equips providers, and enables patients to navigate their cancer journey with confidence and support.
Cancer care is changing in Kenya. Empower 1.0 gave thousands access to early screening and treatment. Empower 2.0 takes it further, digitizing the journey for faster, smarter care.
As a country, we are determined to ensure that every Kenyan, regardless of where they live, can access quality, timely, and dignified care. In this case, specifically cancer care.
The Empower 2.0 program is going to focus on the successes of Empower 1.0, which is the integration of breast and cervical cancer in the primary healthcare system. The focus will also be to understand the patient journey from an end-to-end perspective, starting from awareness, screening, diagnosis, and to treatment.
We are able to do patient link-up, patient follow-up, and also patient follow-up in terms of management, and also post-management follow-up, helping us to reduce allowed times toward the follow-up and the treatment of this patient. As area, the way they have been doing, it's more manual registration, but nowadays when we're having this Empower, it's also enabling us to have that dashboard program whereby it can give us the entire detail of our patient, from their registration, the time they have been seen from the facility, the time they have been referred to the facility of investigation, and the facility that they are doing management.
Faster diagnosis, quicker treatment, real lives changed.
Over the past year, we've seen firsthand how digitization can accelerate impact. What began as a pilot in 20 facilities has now scaled to 76 sites, with 56 additional digital sites and 200,000 patients screened for breast, cervical, and prostate cancer.
Local evidence generation and data for decision making is critical towards advancing the future of cancer care. We have understood that digitization is important to align to the universal health agenda, and this milestone complements integration to the digital health superhighway. For that reason, the impact of Empower has demonstrated that the future of cancer prevention and control is digital-led.
The Empower program, provided for real-time data, is a great asset that enables our patients, our clients, to access care without loss to follow-up and improve outcomes. This progress has not been possible without working with all the stakeholders in this space, collaborators who have provided an opportunity to be innovative, and this has been enabled by working with private sector and other stakeholders. Our vision is very clear: to provide digital infrastructure that empowers counties, equips providers, and enables patients to navigate their cancer journey with confidence and support.
Cancer care is changing in Kenya. Empower 1.0 gave thousands access to early screening and treatment. Empower 2.0 takes it further, digitizing the journey for faster, smarter care.
As a country, we are determined to ensure that every Kenyan, regardless of where they live, can access quality, timely, and dignified care. In this case, specifically cancer care.
The Empower 2.0 program is going to focus on the successes of Empower 1.0, which is the integration of breast and cervical cancer in the primary healthcare system. The focus will also be to understand the patient journey from an end-to-end perspective, starting from awareness, screening, diagnosis, and to treatment.
We are able to do patient link-up, patient follow-up, and also patient
really good. We are seeing in the Western countries, 90% of children survive. And yet in our local setting, we are seeing only maybe 20% of our children surviving. And the core issues that we've identified is late diagnosis of these children. So this slide just represents everything that is important in this fight against childhood cancer. And the first one is the case finding referrals. So you'll notice some of these signs and symptoms for childhood cancer can be confused for infectious diseases. They'll think it's meningitis, malaria. By the time a child is actually referred for further diagnosis, they'll have stayed in the system for a while. So for the healthcare workers, our call is that there are some posters around on the early warning signs of childhood cancers. We have some partners supporting this. Kindly look up on the early warning signs of childhood cancer. It can even just be a headache or a bump somewhere on the body or a child who's bleeding easily. Such are the warning signs. Then, of course, we need diagnostics. We need comprehensive treatment centers. So the treatment centers for childhood cancer currently are 3. The KNH, KUTRH, and MTRH. So if you find a child who is suspicious for childhood cancer, please do not refer to level 4 or 5. Refer directly to KNH, KUTRH, or MTRH, and they have their contacts. We have some KU and KNH and MTRH representatives, and you can actually get a hotline to refer those patients. Then the registry that is coming up, Dr. Gladys Chesumbai from NCI, there's a cancer registry that we are going to develop just for the childhood cancers to enable us really get the whole perspective. So kindly, let's support our children to get better outcomes. Thank you.
Thank you, Dr. Hari. I believe most of us have taken our tea, or at least served, and we are now taking it. So without much further ado, allow me to welcome the king and queen of condoms. Makofi. You don't sound enthusiastic. You're going to discourage the queen, you people. And yesterday you were very excited about what the king had to say. Kindly, tuwapigie makofi ya kilo. Asante.
Power. Let me see. Power. Power. Freedom. Freedom. Wisdom. Kingdom. Condom. Kama professor, governor anaguza, hebu angalieni. Power. Freedom. Wisdom. Freedom. Kingdom. Condom. Makofi kwa kila mtu. Thank you very much. Today I'm with the Queen of Condom, Gen Z Queen. And she will introduce herself and what she does. Alafu tufanye our presentation.
I hope it's still morning. Good morning, everyone. Sharon is my good name. I'm the Queen of Condom in Kenya and in Africa. You say the only one in Africa. Yeah, so basically my work is on teenage pregnancies. I focus on the teenage mothers and also ending gender-based violence cases in our communities. Thank you so much. So I'll take it on to the king to continue.
Thank you very much, Queen. Queen was in KU when she joined me, and I visit a lot of universities and secondary schools and colleges because, surprise, in our country today as we talk, we have more than 200,000 young girls between age of 11 to 19 who get pregnant every year. The highest was 2017, we had 378,000. And today I want to clap to all doctors who are seated. If you are sitting next to a doctor, mpigie makofi. If you are a doctor, jipigie makofi. Because we must change this narrative. Tuko pamoja? Of children having babies. Children having babies. Thank you, Queen. Maybe katu hapa tutaoneshana. Yesterday we did a demonstration on how to do because of we have a lot of what we call gonorrhea, throat gonorrhea because of oral sex. Tulifanya hiyo. Tukasema also we have what? Throat cancer, which is brought by HPV. Sindio? But I didn't do it for men. And allow me to do it kidogo because we have our governor here. Permission granted to do for the ladies getting gonorrhea of the throat through daktari, through, yes, our governor yesterday, we did a very quick demonstration, quick one. And I want to do it now the official way, condom demonstration. And before I do that, because I'll forget, where is Dr. We went to India with a doctor. Where is Dr. I want to announce something I forgot. King of Condom, I have so many titles. I'm a children ambassador. Children with heart problem, through the initiative of King of Condom, I got some donors in India. Any child with heart problem that cannot be done in Kenya, I have a way to support that child to be done the operation or surgery in India, and the company pay 80%. The NGO pay 80%. Today, and I want you to clap for me. I want doctors to clap for the King of Condom. I have done 30 children in Kenya, in India. 30 alone. And I have done 2 cases of cancer. For children, the organization support by partially paying. One is here. I don't know, I have not seen her. I went with 2 doctors from KU, from Kenyatta Hospital, and that chance is still open. We can share and we can help. If I grow up, I want to be a doctor. Nipigeni makofi. Thank you. Haya. For male condom, don't check the expiring date when you are in you want to start the activity. You can't see the expiring date during that time. You can't. Expiring date need to be checked before the correction of the condom, the buying place. Sindio? Check the expiring date. Squeeze the condom. Check whether there is air. Tear the condom, not with your teeth, not with scissors, in a very simple way. The right way to put on condom, and that's why I have the Queen of Condom, this is the inside and outside. Make sure the lights are on. Those times to put condom, men were putting condom in the toilet and then they come covering down. That time is expired. Ladies, witness the man is putting condom in the right way. Today we have cases of men who tear condom. So, pinch the condom on top, the man to pinch, and put on a very erect penis, then queen, roll down. Your queen will roll down. Roll down. Mpigeni makofi. She know how to roll down. Now, why? During the rolling down, you are able to see and also supervise the nature, and some cases, we have a lot of STIs, you have some pimples, you can be able to see, and you are sure that you have been able to roll down the condom. The other thing I want to emphasize about condom is men. Can you say hi? Men. Prepare women. Prepare women. Prepare women for the muscles to relax and the vagina to wet. We have a lot of condom bursts because some people are not well prepared. And this is what we call condom burst. You try to push yourself in somebody whose muscles are tight and is very tight. And this is the condom burst. And if you are drunk, you are not going to know the condom are busted. You'll touch here and you feel, hey, these are sleeveless condom. Can you say sleeveless condom? And somebody will get pregnant, get HIV and STIs. We have genital warts. It is trending now because We also have a lot of men having sex with men, and genital warts can be in the anus, penis, vagina. And you know, doctors, do we have treatment for genital warts? Do we have treatment for genital warts? At early stages. For men having sex with men, some can't go to the hospital because they fear, because of stigma. So they sit with those infections, and by the time they go to the hospital, it is bad, it needs operation. These are how to remove condom, and these also, men, I have something for you. Carry your condom, dispose yourself. We have cases that when somebody drop condom in the dustbin, somebody pick them, they go, and maybe you feel that you have a child with somebody somewhere, and you have never even seen that person. DNA, when it's done, positive, but you have never seen that person. Yeah. We have cases where the girls are using the sperms for other things. The final thing is the female condom. This is a female condom. How many people have never seen a female condom? Good. You'll come to a stand. This is a female condom. It is wonderful. Although we have shortage of female condoms. Maybe Governor, I'll send you. We need a reduction of taxes of condom. We have shortage of condoms. Please do something on my behalf. This is a female condom. Nishikie, my dear. Good. And I have a dummy. Now, female condom have two rings. This one and this one. This ring is to help to insert the condom inside. And it's also add pressure. You squeeze the ring, you insert. You insert. Then with one finger, you continue pushing the ring. You continue. Now, in human being, you don't expect to see the ring coming out from behind. You can see. This is a position. This is a position. With female condom, we give the lady about 10 minutes so as the condom can get the warmth and fix to the walls of the vagina. So it's not like men, you put condom and then you jump. No, you put condom and then you relax. So, but you don't count at 10 minutes to go 5. No, you are busy doing other things, so the condom get the warmth. Now, for the penetration, men will not put on condom, will come without condom, and will be guided. He might come in a hurry and pass through bypass. We have a lot of bypass. This is not safe. You go through the super highway. Then you remove, you roll the condom 3 times. 1, 2, 3, because the sperms are here, and then you pull. Now, yesterday we also talked about the oral sex for men. For ladies, we use this. In advanced countries, they have dentodam. Yes, you know dentodam? I can see. You know dentodam? Hello? We have dentodam. It's for oral sex. Now, we are Kenyans. We can improvise. Tear the condom. A dentodam is a sheet of rubber. You tear like this. If you want to do oral sex to a lady and you don't know the status of the lady, maybe in terms of the HPV, you can paste the condom on the vagina and then you do what you do and you're happy. If you don't have the condom, there are some papers, foil papers. We cover water. Please protect your throat. For men, this because of our governor. For men, ladies can do this. This is the inside, this is the outside. Queen should have done this, but let me do. And you are safe to do your oral sex to protect gonorrhea and the HPV. The same energy that you are doing in condom, we want to do it in cancer. We have the skill, we have the know-how, we need information, because for prostate cancer have nothing to do with sex. But the information out there, men are told for you to avoid prostate cancer, you need to have 21 ejaculation per month. Those are 21 sex activities per month. Now you can imagine yourself, 21, to avoid prostate, and they have no relationship. So can you empower us to give people the right information? And if the wife cannot manage to do 21, now people go look for other options. Thank you very much. Makofi for us. For children with supportive and cancer, children who need to go India, my number is 0722. You can write condom 0722 128 238. You can call me anytime for prep, for condom, for support of children. Makofi for us here. Yanguvu.
I don't know what to say. But that's the king and the queen of condoms. And the beauty about the queen is that we are so much used to our queens that are old. But our queen is a Gen Z queen, right? So that's the beauty of it. And she knows a thing or two about the use of condoms. And trust you me, she's doing a good job with Gen Zs. I think that conversation now must be brought to a close. As exciting as it is, so that we can get on to the next conversation. So ladies and gentlemen, the next conversation that we are going to have is strengthening the cancer research ecosystem, progress from 15 NCIK funded projects. And the chair of this session is Dr. Samuel Gathere. This is the 15th panel. Very good. So the chair, as I said, is Dr. Samuel Gathere. Where is Dr. Samuel? Please come up on stage. Thank you. Let's appreciate our Daktari from NCI Kenya. And the other discussants here, we have Dr. Emily Koech. Where is Dr. Emily Koech? Dr. Emily Koech. She's from Migori County. Do you have Dr. Emily Koech? All right. Dr. Mohammed Abdirahman, where are you? Yeah, let's put our hands together for Daktari. And then Gregory Sakwa Doctor. He's from Masinde Muliro University of Science and Technology. We also have Dr. Mary Anziani Matilu. She's from KEMRI, Kenya Medical Research Institute. Let's put our hands together for the two doctors. Thank you very much. And to wrap up the first session, we have Dr. Edna Tor from Chuka University. Her background is automated breast cancer screening and detection. Let's put our hands together for Dr. Edna Tor. Dr. Samuel Gathere is a member board of trustees at National Cancer Institute of Kenya. He is a senior clinical research scientist at KEMRI. He holds a Master's of Medicine in ENT head neck surgery from the University of Nairobi, and also a diploma in cancer control from the National Cancer Institute in USA. He's a consultant otolaryngologist. Whoa. He has interest in various facets of cancer research. He's currently the focal person of the African Cancer Caribbean Consortium that focuses on disparity. I think after this conference, I need my neck to be massaged. These names are tough. So please, Dr. Ari, take it up. Each participant will have 5 minutes to make a presentation. Thereafter, we're going to invite the other discussant, Asante.
Thank you very much. Good morning, everyone. I want to thank NCI and talk about, maybe just give me a minute, I talk about this session, that the NCI has committed to provide seed grants for cancer research in Kenya in recognition of the urgent need to strengthen local evidence and capacity to respond to the country's growing cancer burden. I think there was a presenter here who talked about this. There's a need for this. And despite the remarkable efforts in cancer policy and service delivery, significant gaps remain in context-specific data to guide decision-making. So this session will shine a spotlight on 15 cancer research projects that were funded competitively, each addressing a key aspect of cancer care continuum, from cancer burden, description, early detection and diagnostics, to palliative care, financing, and policy. The session brings together principal investigators for this research projects to share preliminary findings that will foster dialogue and explore how this body of research can inform and drive implementation and ultimately improve outcomes for patients across the country. So this is a first for NCI to fund, and congratulations to all of you. And we hope that this group will get bigger and bigger, and also more and more money from NCI. So without much ado, we want to have Dr. Mohammed Abdurrahman. So you have about 3-4 PowerPoints. I think this is for Dr. Emily. Emily, oh, you came in. Oh, Dr. Emily from CHEB, optimizing cervical cancer screening among women of reproductive age among Fisher folk community through HPV DNA PCR testing in Migori County. So a few slides just to say what you're doing and how far you are. And remember, this is not a scientific conference. This is a general, so make it palatable for everyone. Thank you. Go ahead.
Thank you so much. Good afternoon, ladies and gentlemen. Thank you for the opportunity. My name is Dr. Anita Bisera. I'm a co-principal investigator. On behalf of our CEO, Dr. Emily Koech, I'll take up the presentation. So CHEB is Center for International Health, Education and Biosecurity. We're implementing largely HIV programs all the way from prevention, care and treatment. We are in 10 counties in Kenya. And for this particular purpose, we were implementing, thank you. So we were doing an investigation among the fisherfolk community in Migori County, where we were determining the prevalence of high-risk HPV among women of reproductive age among fisherfolk community. So we understand the prevalence of HIV and the burden of HIV around the lake region, and especially in Migori, where it's a very high rate at 10.4, which is ranking the third in terms of prevalence of HIV. And so therefore, even the fisherfolk community are more at risk and more vulnerable of getting HIV as well as HPV infection. So it would make a lot of sense if we were able to identify the fisherfolk community early with HPV screening, with the gold standard, which is HPV DNA testing, so that they treatment. So we were able to do this study. Our sample size was 800 women aged 30 to 49 years of age, and it was a mixed methods, qualitative as well as quantitative study. All the ethical considerations were followed through. We sought AMREF approval to be able to carry this, and we obtained consent from all the clients that were participating. The other thing to note is that it was voluntary, and we had massive consent from the clients who were able to participate in this study. So we were able to get the test kits from Roche, and these were self-testing. self-sampling test kits, which, as we heard from the morning sessions, they are preferred by clients, and they are actually higher quality. So we were able to get that, and we have a testing lab within Migori County, that is at Migori County Referral Hospital, where we were able to analyze all our samples with a very short turnaround time. Within a week, we were able to get our results and deliver them to the clients. Equally, we were able to do a qualitative research where we had 6 focused group discussions of about 6 to 10 participants in each, and also 6 key informant interviews, where we were able to interview the clinical service providers, and we'll be able to share results for the same. So in total, we had 880 women that were sampled, but from the samples, we'll see the analysis, and then also overall, we had 23% of the samples turning positive for high-risk HPV DNA, that is 16 and 18. And we were able to proceed on to do visualization using VIA, and 24% were positive for suspicious lesions, and they actually received treatment. This is just the graphical presentation of the same. As you can see, only 3 samples from the self-corrected samples of 880, only 3 were rejected. And so the analysis was done for 877, out of which positivity is at 23%, where we had 201 HPV positives. And this is the breakdown of the positivity, where we have HPV 16, 22 of them, 18, 21 of them, and 16 and others, as you can see in the breakdown. So essentially, we were able to pick all the high-risk DNAs. We were limited in terms of other genotypes, but with good testing modalities that we have in the lab, this can be analyzed further. So using VIA for the positives that were there, the 201, 92% have actually had VIA visualization, and from those, we've been able to identify and treat 44. 1 declined treatment and is still on follow-up. And we had 2 suspected cancers. One of them has actually been referred and has received treatment from a peripheral site. Those are preliminary results. We are continuing to analyze the qualitative data that we have, and we'll be able to share this in a publication as well as in other forums to be able to share with the population what the key informant interviewers or interviewees were able to say about HPV DNA, as well as the participants of this study, what they felt about this particular study. So the other thing, of course, we'll be able to follow through their clients that have not been treated, and we are keenly in contact with them to make sure that we reach all of them, to visualize and treat those that require treatment. So we'll also be following up the negative. As you realize, majority of the clients were actually HPV negative, and we'll be following them up with subsequent tests, given that these are high-risk population in terms of HIV prevalence and also likely to have HPV. So we'll be following up with subsequent HPV testing. We hope to publish our manuscript for the wider audience for scientific knowledge and building up that knowledge capacity. So we thank you, and that is all for this year project. Thank you.
Thank you very much for keeping time within 5 minutes. Thank you very much. So if you have any question, we'll kindly note your questions. We'll take the questions after all of them are presented. Okay? So we go to the next presenter, that is Dr. Mohamed Abdurrahman from Wajir County.
Good afternoon. Distinguished guests and colleagues, good afternoon. My names are Dr. Mohamed Abdurrahman from Wajir County. And let me take this opportunity first to thank and appreciate National Cancer Institute for giving us this opportunity, bringing us together, 1. Number 2, so that we can be able to jointly take action. Secondly, also, I want again to appreciate them for giving us an opportunity to carry out a very important research in Wajir County. As you are aware, Wajir County is in the northern part of Kenya. A lot of challenges going on there. But first, before I start, I want to give you why we were funded to do this research. The research here is the burden of cancer in Wajir County. Population-based study. Why we went for that is because first, we don't have data. Whether it's a local data, or whether even in the a comprehensive cancer registry does not cover anything on Wajir, and even basically even the other counties across those regions. So we were inspired to do that study because we don't have data in the county. So for long we were data blind spots. If you look critically, for long we were navigating in the dark. The national context, cancer is Kenya's third leading cause of death, and the burden is still rising. The critical gap, the national data is incomplete. Wajir County was a data blind spot with no reliable cancer statistics. That's one thing we need to appreciate very much. So the goal was to move from assumption to evidence proving, providing the first ever comprehensive data on the cancer burden in Wajir County. So our response was basically to undertake this research. So we were able to do a rigorous ground level study in collaboration with our partner, National Cancer Institute. The methodology was basically a mixed approach, where quantitative and qualitative to understand what and why. The scale of the survey was basically, we were able to sample 1,410 households stratified across urban and rural communities for a representative picture. That is covering about, the total population was 147,000 households in the county. So we were able to pick 1,410 households, and that formula, we were able to use Yamene formula. Next, please. Next slide. So to address the gap, this is the preliminary findings that we found from the study. The prevalence in general is that the overall prevalence of cancer in Wajir County in 2024 was 3.29%. That's very high. Now, if you break that one down, you'll come to see that actually about 52% of all the types of cancer is esophagus cancer. 52%. That's quite high. Followed by prostate cancer, 11%. And then we had also others like stomach cancer was 9%, and then colorectal cancer was 7%. Quite very high. The other prevalence is that the burden is not evenly distributed. We have 6 counties, sub-counties in Wajir County. Wajir East sub-county has a significant proportion of cancer. 35% of all identified cancers come from Wajir East, followed by Wajir South, 22%, and Wajir West, 15%. The disease predominantly affects our elders. Over 71% of cases are in the range of 51 to 80 age brackets. And the males takes the bigger share with 54%. Again, this is for me the most critical part of it. An overwhelming 83% of cancer patients in our study were diagnosed at advanced stage, stage 3 and 4. That is 83%. This is where the battle is already lost before it has truly begun, because as you are aware, treatment is less effective by that time and more costly, and the outcomes are tragically poor. This single statistic of 83% of cancer diagnosed at a later stage explains why cancer mortality is so high in our county. Currently, it is 76% of all the cancers die within the first 6 to 12 months, within a year. 76%. Of these 76%, the majority are esophageal cancer. 83% of them die within 6 to 8 months. Quite a crisis in Wajir County in respect to cancer. What I assume, we see some of the reasons what we can associate this late diagnosis is we have a crisis of awareness. Over half of the population could only name one cancer symptom. 97% have never been screened for cancer, 97% of that population, 1,410, the sample that we took, 97% they have never been screened. 82% have received no preventive education. 82%.
Dr. Mohammed, 1 more minute.
Yes, okay. That is, then the other thing that is barrier to access. 45% reported difficulty accessing healthcare. 70% believed that treatment was even not available in the county. In conclusion, this is just the preliminary result. Actually, we are still doing our analysis further. And in conclusion, we say that our study has moved Wajir from data unknown to data informed region. We now know the scale of the problem, the specific cancers we must target, and the systemic weakness we must address. Thank you very much.
Thank you, Dr. Mohammed, for that interesting. So keep your questions up to the end. Dr. Mary Nziani from Kemri is next.
Good afternoon. My name is Dr. Mary Nziani Matilu from Kenya Medical Research Institute, and I'm happy to be here to share what we are doing at the Kenya Medical Research Institute with the support of the National Cancer Institute in regard to cervical cancer screening. Myself and my colleagues from the Kenya Medical Research Institute received some funding from National Cancer Institute to undertake this study. May not have been adequate, but it was good to start us off. And we wanted to look at high-risk human papilloma virus and cervical abnormalities in women attending selected health facilities in Makueni County. We wanted to look at the prevalence, risk factors, and also look at the knowledge and perceptions of the healthcare workers and the women who will be taking part in the study. So we have talked about cervical cancer a lot in this conference, and in 2023, Kenya had an estimated 5,236 cases of cervical cancer, and 3,211 deaths in that year. And this is a big problem, as we've already learned. We also do not know the different types of genotypes that are circulating in our country, given that we only focus, a lot of the time we focus. We also want to determine the association between the extended high-risk genotypes and the abnormal cervical findings. We will also look at the factors associated with the extended high-risk genotypes and the cervical cancer abnormalities. And besides that, we've talked about barriers and other issues around cervical cancer screening. So we want to assess the knowledge, attitudes, beliefs, perceptions, behavior, and practices around HPV and cervical cancer screening. And that is in the women who will be taking part in the study and the healthcare workers who will be looking after them. So we are using a mixed methods cross-sectional design. We are going to have both a quantitative and a qualitative research design to look for our data. The study sites are in Makueni County Referral Hospital. We have Makindu, Kibwezi, Sultan Hamud, and Boni County sub-county hospitals to carry out this study. And we are targeting 1,100 women who will be visiting the facilities for any kind of healthcare, but more so for reproductive health services. We are going to use the quantitative design of research. We'll use a questionnaire to collect data on the socio-demographic factors of the participants and also look at risk factors for HPV infection and cervical cancer. Then we'll do visual inspection of the cervix to check for abnormalities on the cervix that we later associate with what we'll find as the HPV genotypes in each participant. We'll do HPV testing on the BD Viper system, the HPV assay of the BD Viper system by BD Onclarity, called the BD Onclarity HPV assay. In the qualitative study, we'll conduct focus group discussions targeting healthcare workers and the participants in each facility. So for each facility, we'll have a focus group discussion with the healthcare workers and another focus group discussion with the participants.
Dr. Mary, 1 minute.
So far, we finished the preliminary issues around the protocol development. We acquired the regulatory approvals and started the study at the beginning of this month. We've started the fieldwork, it's ongoing, and so far we've collected 135 samples awaiting testing at the laboratory, which we'll do on a rolling basis. And the rest of the issues are pending, and that's how far we've gone. We expect to get good data that will inform policy. Thank you.
Dr. Mary. Dr. Edna, you have 3 minutes, okay? I think we are out of time. We are running late. So it's just a summary of what you're doing. So try to stay within 3 minutes, starting now.
Okay, thank you. So my name is Dr. Edna To from Chuka University, and I was the principal investigator for the research, automated breast cancer screening and detection, which is simply an AI-based solution or artificial neural network-based solution using some of the technologies like modified convolution neural networks and capsule neural networks to be able to use that in order to detect or screen cancer or for early screening. And the intention for this is to, if we screen earlier, as most people have talked about here, then it means you'll also deal with it early enough before it progresses to some advanced stage. So in terms of the methodology that we used, as we've said, this is an AI-based solution. So we are using computer science solutions. So I'm a computer scientist, but I'm applying my computer science in the field of healthcare. we collected data, or for us to be able to develop such a system, we have to collect data, and we need massive amount of data. Although we had some challenges, initially we had selected 14 hospitals, but when we went to the field, we realized that out of these 14 hospitals, it's only level 5 hospitals that actually have mammograms. The rest of hospital would rely to some private facility to be able to get these mammograms. So the facilities that we looked at, or that gave us data, Meru level 5 hospital, Kerogoya level 5 hospital, Nyeri level 5, Outspan, Embu, we have Muranga. We had a number of hospitals mixing the private and the public facilities, but we realized, I think we had about 5 mission hospitals. It's only Outspan that has got, from the region of Mount Kenya. We went to Mount Kenya region because from, again, the statistics, the Mount Kenya region have more prevalent cases of cancer. And we again went for breast cancer because breast cancer is one of the leading cancer. So we collected data in these hospitals. However, for us to be able to develop these models, we need massive amount of data, especially the technologies that we are using, which is the convolution neural networks. They require a lot of data. So that's why we went for, we need a lot of data. So we had to supplement this with publicly available data for us to be able to develop a good model. So these were the classifications for the data. We had BRADs. So the classification are based on BRADs, not malignant and normal, and maybe the case of, so we use BRAD. So there is BRAD 1, there is BRAD 2, which is from the previous slide, BRAD 3, and BRAD 4 and 5. So BRAD 1 and 2 are normal, BRAD 3 malignant, BRAD 4 and 5 is highly suspicious. So we categorize them into 2, the normal and the suspicious. Because this is screening, we want to show cases that are normal so that you don't go to advanced stage. And those that are suspicious can now go to the advanced stage. So we were able to develop a model. And the model, we developed various, or we looked at various technologies. These are basically scientific, I don't want to deal with them. But what we were looking at is basically the accuracy. How accurate is a given technology? And there are a number of technologies. So the one that we were really working on is what is called CapsNet here. So that is our main technology, and that is basically what we had proposed. So we went ahead and developed a model using that CapsNet, and it was actually able, or when we uploaded some of the images which were not used in the building of that model, it was able to detect that for an image that probably was a BRAD 4 or BRAD 5 as what? Suspicious. And the one that is normal, it's basically giving a normal class with some confidence level. However, again, as you can see, the confidence level is still very low. In medical, we at least want to go up to 100. So we are still not yet there. So we are working on that. The other thing that we had proposed, we have actually developed the model. So the model is available. You can access it. It's publicly available. I've shared the link. Maybe you can go try uploading an image and see whether it's going to give you a label, a BRAD. It's normal and suspicious in that case. So that was the work. It's still ongoing. We intend to publish the work. We also intend to run more experiments in order to be able, our intention was to use the 5 BRADs, but because of the number of data sets, it was not giving us very good accuracy level. So that's why we went with the 2 classifications. So, however, we are still going on with the research. Thank you.
Thank you, Dr. Edna. We could have a few questions, maybe 1 or 2, 3 questions to the, oh, sorry. How did you get past? Okay, thank you. So please take 3 minutes because we have another 10 of you presenting. So
Thank you.
just summarize. Thank you very much.
Thank you. I bring you greetings from Kakamega, where Masindi is based, and Kakamega County has got a high prevalence of risk factors to cervical cancer. My research project is on co-designing culturally acceptable strategies to optimize uptake of HPV testing by use of self-sample collection with the aim of increasing cervical cancer screening. So apart from high prevalence of risk factors in the county, also it has got very low uptake to screening. We do know that cervical cancer has got is a huge burden. Cervical cancer is a huge burden, as we have already seen, but the key to addressing that burden is screening. Unfortunately, less than 4% of women go for screening. Reason, because of a variety of fear. Now, what did we set out to do? We set out to explore perceptions of women about self-sample collection. Using that particular data, we were to co-design a culturally acceptable strategy to optimize self-sample collection for HPV testing. Okay, so we've gone up to the next stage. Now, having said that, what have we done so far? This is purely qualitative approach integrated with implementation research. So far what have we done? We have already done community engagement activities, including setting up, sorry, you're quite fast, including setting up of inception workshops, community dialogues, community entry workshops, sorry. We have formed and trained community advisory committees. We have done training of community health promoters towards self-sample collection. We've also done assessment of the perceptions of women and other stakeholders towards self-sample collection. In addition, because we also have got other stakeholders on the ground, we have done some partnerships already with the, not really done, but in the process of doing an MOU with like-minded stakeholders, and the first on the list is the First Lady of the county, who is already concerned with cervical cancer screening. We are in the process of co-designing culturally acceptable strategies to implement uptake of self-sample collection. So far, preliminary results is that stakeholders have accepted this particular strategy as quite convenient and as an alternative to clinician-based cervical cancer screening. However, it has also got some barriers. Kakamega being basically a rural town, we have got issues of misconceptions about self-sample collection. Okay, so what are the next steps that we have done? We are already in the process of applying the culturally acceptable strategies. This is by way of training and screening targeted 200 women on self-sample collection. We're also in the process of establishing partnerships. First on the list is the county government. Second is the First Lady of the county. In the way of mobilizing awareness, advocacy, and mobilization of self-sample collection. And lastly, we're also reflecting on the lessons learned and the pain points along the line of self-sample collection. That is it. The work is in process. Thank you so much.
Thank you very much, Dr. So, unfortunately, I've been informed we are really out of time. We were meant to run this program, this session 11 to 12. You see where we are. So we will not take any questions kindly. So let's get the next presenters. But thank you very much. Let's give them a hand. As they go down, I think I see the chair, our chair there of the CEO. I hope we'll get a scientific conference maybe next year when there's no summit, because I can see there are very interesting studies. maybe an NCI-led scientific conference to have this. Just a thought. Thank you.
Thank you, Dr. Harry. So we'll move straight to the next set of presenters, Advocate Claude Kamau from Strathmore University, Dr. Joash Abere-Migosi from University of Nairobi, Dr. Benea Obanda, PhD from KEMRI, Dr. Brian Mwombuna from ScanLab Center Nakuru, and Dr. Gilbert Olbara from MTRH. Karibuni sana. Tuwapigie makofi ndio wapate moto wa kufika haraka haraka. Karibuni, karibuni. Ni kama wanataka muwapigie tena makofi ndio waharakishe. Asante, karibu.
Okay, thank you very much, Jess. Okay, you've all run away from me. You think I'll cut your time, eh? Okay, thank you. So, Claude Kamau, you can start. We have 3 minutes. Just summarize, and then we'll try to get you a slot next year.
Good afternoon. My name is Claude Kamau. I'm a lawyer by training, and by profession, I'm a legal researcher in intellectual property law and bioethics, based at Strathmore Law School and the University of KwaZulu-Natal in South Africa. So this study relates to benefit sharing, law and practice in the context of cancer research in Kenya, funded by the NCIK. I'm the principal investigator. My co-investigators are Professor Donrich Thalda at the University of KwaZulu-Natal, Professor Peter Munyi at the University of Nairobi School of Law, and Dr. Faith Kabata at the Kenyatta University School of Law. So the basic approach of this study is that it is at the intersection of law and bioethics. So therefore what we're looking to see is whether we can yield any socio-legal insights from intellectual property law and bioethics to specifically inform the mindsets of the stakeholders in the cancer research process. So these are researchers, research funders, research participants, and communities at large. So we're looking at the whole spectrum of cancer research, and this is what is encapsulated in that spectrum. So the angles are philosophical. Yeah, thank you. So philosophical questions, legal questions, sociological questions, and contextual questions. So in terms of the philosophical aspects, we're trying to resolve the decades-old debate as to what constitutes a benefit, who is a beneficiary in the research landscape, and what obligations exist in both a linear and horizontal, vertical and horizontal level between the stakeholders in research. So what we found is partly that we don't have a proper conceptualization of what benefits are in both health research and in cancer research, as well as in genomics. So that's one of the problems we're trying to resolve. And those are the 4 frameworks in a philosophical sense. Principalist ethics, which is constituted by the body of what we call soft law, declarations and conventions that are relevant in health research globally. We have theories of justice. This is distributive justice, commutative justice, and so on. We have the theories of exploitation. So a lot of benefit sharing claims are couched in the language of avoiding quote-unquote exploitation in the context of health research. So we have some important findings of what actually constitutes exploitation and what doesn't. From a legal perspective, we're looking at questions of lawfulness. Benefit sharing is in fact, by our finding, illegal in some countries, South Africa and Nigeria, for example. Permitted in contexts like Kenya, but the regulatory aspects are quite vague. We have the very important cog of intellectual property, of ownership, of consent, and the taxation of research income. We also have sociological questions relating to trust. We have findings as to what motivates participants to engage in cancer research, and what the implications of lowered trust would do for cancer research outcomes especially at the upstream level of research, which obviously then translates to the downstream level of cancer medicalization and outputs. And then finally, in the contextual angle, we are looking more concretely to see what is happening in the Kenyan landscape. So what are the incentives for the biotechnological companies that are involved in cancer research to share benefits or to approach research in such a way that biobanking and clinical trials are designed to share benefits with research participants. We're looking at disease and patient advocacy. Some of you in the room here, we've already engaged you in the first phase of data collection on this. And then we obviously have the initiatives that have been taken by those individual entities. So these are the preliminary observations. I don't think we have the time to go through all of them, but what I'd like to say is that, well, the methodology is twofold. It's all qualitative research, and the first limb entails in-depth interviews and observation, and then the second limb entails deliberative public engagement, which is a methodology that has been borrowed from democracy studies, and basically we are trying to examine the opinions of lay persons who have been trained on these concepts, kind of like in the TED Talk fashion. You measure opinions before you train, and then opinions after you train, and then measure the impact. So that is what we're trying to achieve, and that is the phase at which we are after having received regulatory approvals in Kenya and South Africa. Thank you.
Thank you, Cloud. Dr. Josh Abere Miguso, University of Nairobi.
Good afternoon, everyone. I'm Dr. Angeline Chepchirchir, co-PI, working with Dr. Joash Mikosi. I want to disclose that currently I'm working with the County of Nandi. I'm the current CEC in charge of health. But at the time of application for this grant, was still a University of Nairobi employee. Thank you. So our research is on the health workforce, taking care of our oncology patients. I think this is a topic that has come out since Monday, that we do not have enough workforce or specialized, trained healthcare. Apart from their skills, their ability to work in diverse environments and be able to adapt to changing situations and be able to provide the best care for their patients. So it has different levels of like-it skills, questions that is going to capture the suitability of the worker besides their qualifications from the academic training. So we have preliminary findings. Because of time, I will just summarize that the findings show inadequacy in the capacity for oncology care, and there's also poor distribution. You'll find that the urban counties seems to have better skill sets than the rural counties, and we know the reasons why. It's usually difficult to retain health workforce in areas where infrastructure is poorly developed. There is also inadequate and poor distribution of oncology services. A county like Nairobi will have better distribution of these services as compared to a rural county like Marsabit or Samburu or anywhere else. There is need for PHC model of care to increase coverage. Everybody has mentioned the importance of promotion of preventive interventions. Let's use the PHC. Probably this is the next focus so that we have much of our resources here. We get more of our trained workforce working in the primary healthcare facilities. And we also emphasize on interprofessional collaboration. This has been noted to be lacking. Most of the workforce work in silos. And lastly, consolidation of human resource for greater impact. Can we have the highly specialized workforce in our regional centers, and we improve on the referral pathways so that we maximize on the limited human resource that is within our disposal? Thank you.
Very much. Now we go on to the next presentation, Dr. Binia Obada from Cambridge. Try to keep within 3 minutes.
Good afternoon. My name is not Dr. Binia Obada. As you can see, I am Anita Omondi. I'm here to represent him because he was not able to be here today. Our research study is on preliminary antimicrobial resistant profiles of bacterial pathogens isolated from cancer patients at Jaramogi Oginga Odinga Referral Hospital Oncology Clinic. Our main objective mostly was to determine the spectrum and antimicrobial resistant patterns among cancer patients attending Jaramogi Oginga Odinga Teaching and Referral Hospital Oncology Clinic. But what we are going to discuss today mostly is our isolation on the gram-positive bacteria, that is Staphylococcus aureus, which has a high burden on cancer patients. Blood infections can be very deadly to cancer patients, more than it can be deadly to non-cancer patients. Staphylococcus aureus was isolated at 69.23%, and non-Staphylococcus aureus, that is coagulase negative, was isolated at 23.8%. As we can see here in this table, the Staphylococcus aureus did show a sign of resistance. And because of this, that is, we also have a burden of antimicrobial resistant pathogens. And Staphylococcus aureus, being that it's a very tough pathogen to treat, a resistant pathogen can be really stressful to someone who is immunocompromised, such as people who have cancer. So in our discussion, we can see that we can use Staphylococcus aureus as a tool in One Health, because we are going to look at it in a molecular way, and we are going to be able to see how we can see how these strains are coming into the hospital by sampling both the health workers and the patients and the hospital environment. By sampling these 3 groups or more, we can be able to look at in the molecular work and see if these strains are coming from the environment, from zoonotic environments, or from the people themselves, that is health workers or any of that surrounding. Thank you.
Very much, Dr. Omondi. Sorry, I'm calling you Banda. Stand up. Then this must be Wanda, not Brian. Eh? Okay, keep within 3 minutes.
So thank you very much. My name is Dr. Dalcy Wanda. I'm here on behalf of Dr. Brian Bobuna from ScanLab, the Research Development Center. So this was an interesting research. I am proud to have said some of my patients benefited from this study, so I'm pleased to present this on his behalf. And the topic was the correlation of MRI using the PIRADS 2.1, looking at it in the context of the histopathology and also the serum PSA. And why this was an important topic is because when we look at cancer of the prostate, it's the leading cancer among men in Kenya. And sadly, we have very late presentation of our patients. So what we were looking at, if we look at the MRI findings, the PIRADS version 2.1, then you compare it with histology and PSA. How does that compare to the rest of the world globally? So what we found, first we had 150 patients that were put in the study. The data we collected was the MRI. We also had the PSA level and the histology, looking at the sample, so that we see, is it benign, is it malignant, or is there no histology for that patient? And also when we looked at the histology, we were very keen to look at the Gleason score. That is what tells us how aggressive the tumor is. And also for that, what was possible, we had the grade group. Then what we found was that the population, as I've mentioned, the age was between 45 to 92 years. And the PIRADS distribution that we found was PIRADS 1 to 2 was 12%, PIRADS 3 was 10%, and of note, PIRADS 4 to 5 was 78%. That just tells us the numbers that we found. When we look at the key implications, there's the sensitivity data that we had, and the PIRADS version 2.1 was very sensitive. It was at 85.7. But for specificity, it was 66.7. And we compared that with other studies that have been done globally, and one study that was done in Kenya, which was the Ochieng et al. So what are we saying? The implications is one, PIRADS 2.1 is really comparable in terms of sensitivity, and that's comparable to the global standards. Specificity is low, and the reason we found was because we need to have a biopsy correlation, especially for PIRADS 4 and 5 lesions. Then in our setting, in the African setting, we have BPH, which is benign prostatic hypertrophy. So as men age, the prostate enlarges with time, and that was a confounding factor. And then for PIRADS 3, which is almost intermediate, we really need to have a histological confirmation. Our diseases are more aggressive, and that was the high Gleason score that we saw, which is known globally to happen in our setting in the African American population. So what are we saying? PIRADS version 2.1 is really efficient because it gives us a lot of data that we can use. It is very specific, and then we can be able to tell high-grade disease. We need to do biopsies for PIRADS 4 and 5. We should have PSA correlation. And really, we need to have a multi-center research on the same to see what is happening to the other centers, and maybe policy to say that we need to do an MRI for all patients in that age group. Thank you very much.
Thank you, Dr. Wanda. Dr. Gilbert, please keep within 3 minutes.
Good afternoon. So I'll go directly. I am the PI for this project. We called it MGene Lab project, and these are my co-PIs. We got funding from NCI Kenya, and you see our main aim was to build capacity to be able to make genetic diagnosis for acute lymphoblastic leukemia. Partly when you go to the sub-objectives to determine which are the frequent gene fusions in our pediatric oncology, and then to identify if we have any other novel mutations that are different from what we've seen in the studies that are done in the high-income countries. So basically, I'm just going to summarize what we did, how we did it, and why. So the reason why ALL, it's because it's the most common cancer in children, accounting for more than a third of the cases. And there's recommendation by WHO to risk stratify our patients using genetics. And this is something we are not able to do because our diagnoses are mostly limited to morphology. When you see the bar graphs on this chart, actually you notice why. The first bar graph on your extreme left shows a child with cancer, and you can see the most common genetic subtype that is there that is high is the purple one. When you look at the adults, it is a different type, which is the orange one. This just tells you ALL is not always ALL. It is very heterogeneous. And why we did it at MTRH? Because it caters for most of the Western counties, 22 counties in Western Africa. It's one of the biggest comprehensive treatment center that is dealing with pediatrics. So how we did it, or how we plan to do it, is that we want to do it in 2 phases. The first phase is to build the capacity of the lab to actually give very validated results. Then the second phase is to sample the patients to determine what gene fusions are there. And you can see it determines, or it requires a lot of work to do. So we had to develop a lot of protocols and SOPs, validate standard operating practices from the lab to the time, from the time that you collect the sample from the patient to the time when you're going to do to the lab. And all this has to be done before recruiting the patient. So where are we now in terms of the progress? The first is buying stakeholders, buy-in, and we've done stakeholder meetings with the scientists, the clinicians, and the oncologists in our unit. This is through a meeting that was done in December. We are now preparing for labs training skills. So we want to train our lab people to be able to actually collect the sample, prepare it, and then finally be able to run the analysis. We hope to hold another stakeholders meeting and then validate our results. I think that is what we can give now. Hopefully we'll give more in the subsequent meetings. Thank you.
Please give a hand to the presenters. So thank you very much. We hope to see you in a scientific conference when you have your full results. Thank you very much.
Thank you very much. And the next set of presenters include Dr. Vincent Were from AMREC, Professor Ntakanyo Paul Njiru from the University of Embu, Dr. Asito Stephen Amolo from the Jaramogi Oginga Odinga University of Science and Technology, and Dr. Bernard Ogutu from CREATES, the Center for Research in Therapeutic Sciences, and finally Dr. Geoffrey Mutuma from KEMRI. Let's give them a round of applause as they come to the stage. Here they are. Chair, take it away.
Yeah, thank you. Thank you very much. I can see 3 presenters. I'm meant to have 5. Are there 2 others coming? Okay. Okay, very good. So I'm not sure. Dr. Vincent? Yeah, you represent Dr. Vincent. Eh? Okay, go ahead.
Okay, good afternoon. My name is Abi Echoka. I'm representing Dr. Vincent Were. He could not make to come today, but I'm one of the co-investigators in the proposal. Okay, so our title of the project was evaluating the effectiveness and implementation of the NHIF/SHIF benefit packages to provide financial risk protection for patients with cervical cancer in both Kisumu and Machakos counties. And why I'm saying NHIF/SHIF was because it was during that period of transition from NHIF to SHIF. Yeah. So our study objectives were to estimate the catastrophic health expenditures among cervical cancer households registered and not registered in either NHIF or SHIF. And the second one was to assess the effectiveness of SHIF versus NHIF and uninsured in protecting against catastrophic health expenditure. And also our third objective was to evaluate the costs coverage by NHIF/SHIF for diagnosis, treatment, and care. And fourth objective was to determine awareness and utilization of NHIF/SHIF packages. And fifth one, exploring the barriers, facilitators to accessing care under both NHIF or SHIF. And the last one was to identify provider-level implementation challenges of NHIF/SHIF. Yeah, so for those who do not know, SHIF now is called SHA, and NHIF was the National Health Insurance Fund. So our study methods, we used a concurrent mixed method cross-sectional study using household surveys. At the same time, we were using key informant interviews as well as focus group discussions with patients, the same as caregivers of the same patients, and cervical cancer patients. And our population was a household with at least one cancer patient who has cervical, breast, or other female reproductive cancers. And why we changed to these other cancers also was because the treatment cost or burden of cancer is usually almost the same for all cancers. So on the ground, we found that cervical cancer patients were living a bit far from each other. So we decided to include also the other reproductive cancers. And then for the qualitative side, the KIs, we interviewed some of the healthcare workers, the nurses, the clinical oncologists on the ground, some of the Ministry of Health officials on the ground, and finance accounts people also on the ground. And the tools for these were structured questionnaires that were assessing catastrophic health expenditure, that is their insurance use, the costs they cover for transport, the household cost for non-food expenditure, and also outpatient and inpatient expenditures, and any other out-of-pocket payments that they made during their visits to the hospitals. And our data analysis included descriptive statistics, logistic regressions, and catastrophic health expenditure incidence estimation. Yeah. So our participants, we had 278 households, and in Kisumu because we did Kisumu, our study site in Kisumu was Jaramogi Oginga Odinga Teaching and Referral Hospital. In Machakos, we used Machakos Level 5, where Kisumu we interviewed 145 households, and in Kisumu 145, and in Machakos 133 households. This is any patient with at least one patient in the household with any of the CAs, breast, cervical, or uterine, or any other that is reproductive. And then for qualitative, as I had mentioned, we did 6 key informant interviews, 8 in Kisumu, 8 in Machakos, which included the healthcare workers and the representatives representatives in the hospitals, the MOH, the oncologists, and all. Then we did 3 focus group discussions, 1 in Kisumu, 2 in Machakos, which included caregivers of the patients with the cancer and also the cancer patients. And we did caregivers because some of the patients will have some of the patients maybe will not be able to give like a clear account of the expenditure. Sorry, can I continue? Yeah. So for data collection, for objective 1, we did catastrophic health expenditure estimations for all the patients. For objective 2, we did NHIF and SHIF comparisons, patients by registration type who had used NHIF before, because most of them, the inpatient costs maybe were being covered by NHIF before. And then the third objective was the cost coverage, where all patients are reporting treatment data. And then objective, that's 3, 4, awareness stroke utilization, where all the respondents were asked. And then objective 5 and 6, we use qualitative KIs and FGDs just to gain deeper understanding. And the FGDs were done for patients, while KI was for doctors and other key informants. And we did the data collection from December up to mid-January concurrently in both counties. Yeah, so our next steps right now, we are still doing the analysis and then the report writing. And just one key finding from all of this was that the outpatient, out-of-pocket expenditure or costs and catastrophic health expenditure, it remains to be high, even with insurance. And coverage, this is because coverage gaps in diagnostics, some stockouts in the hospital, and transport costs push many into catastrophic health expenditures. Yeah, thank you.
Thank you very much. We look forward to getting the full results. That's a very interesting study.
Yes.
Professor Nthakanio Paul Njiro. Please try to keep within time.
Very exact. Good afternoon. Now that we are told to leave research in the lab, so I'm going to tell you only the product of research. And since these days we are told to go research to commercialization, so I'm going to tell you about one of the products we have. And mainly is really to tell you why you should be careful when you are eating food so that you reduce gastrointestinal cancer. That is our objective. And you are saying no aflatoxin, no cancer. That is our objective. And this research, the principal investigator. After doing some research, we realized this is trend of aflatoxin in the Laka-Ngithi and Embu County. The red spots is where we have aflatoxin. And from this, we are going to construct what we call the aflatoxin hotspots, so that we are able to trace it using ICT tools. Now, these are some of the effects of aflatoxin. Cancer due to aflatoxin or gastrointestinal cancer accounts for about 7% of the deaths globally, and about 25% of the food goes lost due to aflatoxin. These are some of the outcomes we are going to see because we are told to mention mainly the outputs or outcomes of the research, not the research itself. So I read the research in the lab. Now, I want to show you one of the products of our research. And this is the product using the ICT tool. Now, the way we are doing, we realize like I have the knowledge, and up to the farmer, they do not have this knowledge of the aflatoxin. So where I started, I get my knowledge as a principal investigator. I train what we call the trainers of trainers. Then the trainers of trainers, they train the trainers of farmers. And the trainers of farmers, they train the farmers. And then they utilize this tool. You identify the contaminated food. You collect it if it is positive. You go and collect it. Then you confirm using the lab. A lot of scientific jargon has been saying now that we use the molecular tools, we do the testing and all that. But I'm talking now not to the scientists, but the users of this product. Then we withdraw from either the farm or the stores, and then after we confirm, we eradicate. How do you eradicate? That's where the innovation comes. We use aflatoxin is caught by species of fungus, aspergillus. So you use another fungus to control this fungus from the soil. And this one, we are partnering with the Karo. This one is a web-based tool. I'm going to demonstrate in a moment, and also an Android tool, and also USSD tool. Why is the USSD tool? Because we are people with generation 2 phone up to generation 5. Now, once you do all this is the product which is now used to, sorry. Oh, somebody is behind me, eh? So, go towards the end. Once you do all that, still, I'm trying to manage I'm trying to manage my time. You need to go to the end. Wow. Okay, I can tell you because unfortunately I'm not controlling this one. Once you go to the end, then there's something called the aflatoxin. The aflatoxin is some very good fungi, which when you put in the soil, they compete with the bad fungus and they eradicate the bad ones. All right? Now, unfortunately, I'm not able to see it, and the person who is controlling me is here. He's showing me another one. Yeah. So, if you are to see, you'll be seeing something like this. This is a good maize which is growing after using the good innovation, you know. So I'm not sure why this person is not really doing. Wow. Now, leave it there now. Click that so that I show the web-based tool how to use. Use it, right-click, and I show you how you are navigating through that. That trick, please right-click. And this is innovation. Yeah. However, I will not show you the details of a lot of the innovation because it's still something going to be patent. Who is controlling me? Yeah, good. This is a web-based app. If you realize you go to our home page, you'll be able to see this is our home page. If you go to what we are about us, this is about us. We are going to give you very good maize, which is really aflatoxin-free. And the problem with this aflatoxin, you can get it from milk, you can get it from ugali you are eating and all that, through the accumulative effect. And that's where you are getting cancer without realizing. No? But we are going to control that. Now, ICCWE, that is our innovation, the tool we are working on. And through this tool, through this tool is explained there. Step 1, identify. Step 2, you collect. Step 3, you confirm. Step 4, we withdraw. Step 5, you eradicate. Now, once you teach the farmers here, we turn the process the other way around. The farmer will come and identify, report it to us, to the lab. We run it there. We get the bad product. The farmer report to us through the app. Once you confirm, then we go and treat. Unfortunately, you may not enjoy it much because I think the person controlling me have not controlled me very well. But there are two innovations there. One, the app, and the other one is the Avlasave. Thank you very much. If you use that link, no.
Thank you, Prof. And sorry, we'll make sure we have a scientific conference when present the full paper. I think the next person is, I think Dr. Sito is Dr. Sito there? No? Then we can go to Professor Ogutu.
Thank you very much. It's a pleasure to be here. I know some people feel I'm out of space, but it's nice to be in an oncology space to possibly share and welcome oncology to the block of health systems. I think what I'm going to look at is that most patients with chronic illnesses don't die from the disease. They die from mental exhaustion. And what are the drivers that? And that is going to happen to most of your oncology patients. And we're just trying to look at some of the drivers so that we can get down to where things happen and really look at one of the common things that the members of the research team whom I work with were all affected by colorectal cancer. One of our colleagues actually died from the disease within a span of 1 year of diagnosis. So we really need to know what really needs to happen in some of these places and look at some of the gaps that we really don't understand that make some of these patients go downhill pretty fast. Because I think we think drugs can do everything, but the drugs just solve a piece of the puzzle when you are treating patients with a terminal illness or a chronic illness. And that's why we wanted to generate information on some of the things that we possibly can ensure that they remain psychologically resilient across the spectrum of the disease. So this is what we really went out to see, investigate and talk with the caregivers and those who are survivors of colorectal cancer. Next. So basically, most of the work is done, and I think it's basically doing the survey to look at some of the interviews and talking with different groups to really understand what is happening, what are their financial and emotional burden that they have to deal with around the disease, are there any support systems that they need, and what are the experiences of those who are having ostomies, because I think really caring for those at home is another problem, and really what they really want to do with themselves as they plan. And this will just help us have a glimpse as we build a research space possibly around oncology at the CREATS, which is basically CREATS is Center for Research Therapeutic Sciences. We look from drug discovery to the shelf and how people survive with the drugs that possibly are given. So I think that's what we needed, because as we get into the oncology space, we really needed to understand what are the issues. Are they different from what we have in infectious disease or other chronic illnesses? And only a few of them who are really well taken care of can say they are having some quality of life. And without quality of life, I think that's one of the biggest problems. And you can still see a number of them still have unmet needs that needs to be really looked at. And the financial burden is something that is still quite a big hardship that they have to deal with. And most of them have to rely on others. And I think these are some of the things that no matter how much framework you put into the care of these patients, the out-of-pocket support is still massive. And if that is not addressed, we might lose them because they feel like they are a burden to the society and they don't have a value for living. And I think these are some of the things that possibly look at this. And we hope that with this, we more or less are trying to get our way into looking at oncology space. And with that, we invite you that possibly if NCI agrees, we would want, and now there's an issue on quality of drugs that we use. We want possibly to work with NCI to train the next therapeutics experts within the oncology space. If you work with me, we want to enroll the first PhD students for oncology in therapeutics, because drug quality is a problem. And if we don't do that, possibly, I think that's going to be our biggest problem. And the CREATS will be ready to possibly work with that. We already have assays developed for most of the oncology drugs so that we can optimize the treatments. And that's what we use to possibly want to start training the next group to see how to optimize those. And with that, we are possibly launching a master's program next year within CREATS and Strathmore University in pharmacometrics. And I think oncology space will be one of the things that, if you guys are interested, we would welcome you. The call will be there possibly early or end of this year for a master's program. It is covering for all students across Africa. Strathmore is going to be the first university to possibly hold that program. It's much more product development from beginning to the end, working with Africa CDC. So we hope to work with you, and we look forward to keeping ourselves together and building the next leaders in oncology space in Kenya. Thank you.
Thank you, Prof, and thank you all the presenters. Let's give a round of applause to all the presenters. You may take your seat. So thank you very much. I will not have questions. I understand we are really out of time, Ashrima. So thank you all. And I'm sorry for cutting your time.
Thank you very much indeed. I mean, Chair and your team, these beautiful ladies want to present to you with some lovely gift hampers. So anybody who was on stage, including the previous discussants, kindly come up to the front so that you can receive your gift hamper. It's now almost coming to 1:30. You clearly see that we're not doing very well in terms of time. But somebody has just reminded me that there is no harm if we extend by about an hour because it is the final day of these great conversations taking place here. So kindly bear with us. We'll finish. Then we're now coming to the final team, and the conversation will revolve around partnerships and collaboration for quality cancer care. And the chair of this conversation is none other than Emily Baracito, Doctor. So, all right, there's another guidance. The researchers, please come up on stage. I've been informed that there is a demand that you take a group photo because rarely do you see a group of researchers together. So you can just have it here. You can just have it here. Let's put our hands together for this group of researchers. Thank you so very much. As the researchers are taking their photo and researching on the best photo, we're going to be guided in this conversation by Emily Baracito, doctor. She is an epidemiologist by training at both master's and PhD level. She has an MBA in strategy and leadership, and she has gone through clinical trials. Yeah, the researchers are going through various protocols to see which one works. So this is how they do stuff. I mean, but at the end of the day, they are going to agree and they're going to give us the best. Emily Baracito, doctor, is the head of strategy, planning, and partnerships, as well as resource mobilization directorate at the National Cancer Institute of Kenya. She's coming up on stage. Let's say our applause to Dr. Emily. Yeah, we're having a lot of conversations because, we started well, we must end very, very well. So you are likely to see a lot of these conversations taking place. Then let's have Adila Fakir from Beckton Dickinson. Adila is a qualified pharmacist with a master's in business administration and over 20 years of experience in the healthcare industry. She's coming up on stage. Round of applause will be good. Her extensive background: she has worked in the pharmaceutical and medical devices and diagnostic industry in both South Africa and Sub-Saharan Africa. Her current role is the Associate Director for Public Affairs and Market BD Africa and has been with Beckton and Dixon for 6 years. Thank you very much, Adila. We're also going to have Taufik Oloruko Oba. He's the head of East Africa Network, Roche Diagnostics. Where is Oba? And he's a pharmacist with over 2 decades of experience leading impactful work across Roche, Pharm, and Diagnostic in Africa. He has expanded diagnostic access for HIV, TB, HPV, and cancer strategic partnerships with government and global funders. Currently heading Roche Diagnostic East Africa, his passion lies in building sustainable systems that connect innovation to real-world healthcare needs. Asante sana. Thank you very much, Oba. We also have Bernard Marcos Oduor. Where are you? Let's put our hands together for Dr. Oduor. He's the Government Affairs and Market Access Sub-Saharan Africa for French-speaking Africa at AstraZeneca. He's an accomplished pharmaceutical executive with over 2 decades of expertise across market access, government affairs, commercial management, key account, strategy, and sales leadership in Sub-Saharan Africa. Bernard has successfully led a team in delivering sustainable growth, strategic partnerships, and access solutions for innovative therapies. Thank you very much indeed, Mr. Oduor. We also have Dr. Peter Thiga. Where are you, Dr. Peter Thiga? Are you in the room? All right, we shall be waiting upon him. Dr. Peter Thiga is a genomic specialist with extensive experience in supporting next-generation sequencing solutions, and he currently serves as a field application specialist at FNS, Scientific, providing technical support. We also have Kellen Thomas. Kellen Thomas, where are you? He's up there. Let's put our hands together for Kellen Thomas. He's a global health leader with over 15 years of experience designing and implementing strategies to expand access to medicines in low and middle income countries. He currently serves as a senior director at Pfizer, where he leads access to health systems program under the Accord for a Healthier World initiative, partnering with governments and health institutions to develop programming in the areas of oncology, antimicrobial stewardship, and vaccines for at-risk adults. We're also welcoming Dr. Beatrice Jep-Ngetich. She is a clinical hematologist and section head of hematology at the Hematology Oncology Directorate of Moi Teaching and Referral Hospital. Let's put our hands together for Dr. Jep-Ngetich. She holds a master's in clinical hematology from Alexandria University. She's a leader in protocol development and multidisciplinary care, and also serves as a principal investigator for AMPATH multiple myeloma program. Her interests include clinical trials in multiple myeloma and lymphoma, as well as expanding hematology training in Kenya. Then we have Dennis Mbogwa. Where are you, Dennis? Yeah, Dennis up there coming over here. He's a seasoned healthcare leader with over 15 years of experience advancing health innovation, strategic partnerships, and market access across sub-Saharan Africa. He currently serves as a program and partnerships lead oncology at Zuri Health, where he derives the design and implementation of access programs in collaboration with the industry as well as public health stakeholders. Let's put our hands together for Dennis. We also have Dr. Abeid Athman Omar. He's a clinical oncology and the head of oncology department at Kenyatta University Teaching, Referral, and Research Hospital. Where is Dr. Abeid Omar? Dr. Abeid Omar. All right, we hope he's going to join us in due course. He is a distinguished clinical oncologist and so as I was saying, he's the head of oncology department at KUTRRH. I also want to recognize the others because clearly, as you can see, the platform is full to the brim, all right? We didn't realize this, but they are here. Yes. So I am being guided that we are going to start with the group that is on stage, and then the rest will pick over after they are done. So they are going to divide their time 30 minutes each, and then thereafter we are going to have the others to come up here and recognize the major sponsors as well as stakeholders who have made this conference to be a success. So without further ado, let's welcome Dr. Emily Baracito.
Thank you so much. Distinguished guests, good afternoon. This is really a great honor to see everyone here. You are all partners. It's partnerships and collaborations. So we are all partners and we are all collaborating. It's only that we could not all come to this side of the stage. Yes. So with that, we are going to have one question for all of us here, and then they will come and they are going to answer. And the question is, what is your organization doing in cancer care? What is your organization doing in cancer care currently? And what are you anticipating looking at our theme, uniting our voices, taking action? And as in National Cancer Institute of Kenya, we appreciate that we cannot do cancer prevention and control alone. We take a multi-sectoral approach, And as you'll hear from our partners and collaborators, they are there are different players in this industry, and each of them has something great to offer in cancer prevention and control. And because of our time, I'm not going to take much time, but I will right away go ahead to invite the representative from Beckton Dickinson, and then we will follow on from Dr. Adila. We will then move to Dr. Tofik and on. Yeah. You're welcome. In Kenya, we say karibu.
So, good afternoon, distinguished guests, colleagues, and partners in health. Firstly, I'd like to say that it's been an honor and a privilege for myself and my colleagues from BD to have attended the Cancer Kenya Summit, a gathering that reflects our shared commitment to tackling one of the most pressing health challenges of our time. As we have heard over the past few days, cancer continues to be a growing public health concern in Kenya. We have also heard that the 5 most common cancers, breast, cervical, prostate, esophageal, and colorectal cancer, which accounts for a significant portion of this burden, sadly disproportionately affects women and the underdeserved communities who are mothers, fathers, children, and friends whose lives have been disrupted or lost. This underscores the urgent need for early detection and screening, which remains one of the most effective tools in our fight against cancer. This gap in access to diagnostics is not just a health issue, it's a matter of equity. So at BD, we believe that health equity begins with access. And that is why we are so proud to be able to collaborate with the Kenya Ministry of Health, the National Cancer Institute, the National Cancer Control Program, to expand access to critical cancer diagnostics, particularly for breast and cervical cancers. Our joint initiative, which we are piloting in Nairobi County, provides an integrated diagnostic center designed to provide mother and child healthcare services under one roof, where women can get screened for breast and cervical cancer using HPV self-sampling, which we heard about earlier this morning, whilst their babies can get vaccinated at the same time. This initiative has been designed to strengthen screening programs, improve linkage to care, and ultimately reduce cancer mortality amongst women in Kenya. In addition to that, over the last few days, we have had important and meaningful conversations with representatives from the various organizations involved in cancer care in Kenya, where we have emphasized our commitment that goes beyond just diagnostics. At BD, we take a holistic approach to healthcare, one that supports the entire patient journey, from prevention and screening to diagnosis to treatment and follow-up, where we are investing in technologies, training, and partnerships that build resilient healthcare systems. We support our heroes on the front lines, which is all of you, the clinicians, nurses, and community health workers, by equipping them with tools and knowledge they need to deliver quality care. We also recognize that sustainable change requires collaboration. That is why we have participated in this significant event, to listen, to learn, and to work together. Whether it's through innovation, advocacy, or capacity building, BD is committed to being a long-term partner in Kenya's cancer control efforts. And together, we believe that we have the power to change the narrative, to move from late-stage diagnosis to early detection, from fragmented care to integrated systems, from despair to hope. So thank you for your dedication, your leadership, and your partnership. I want to emphasize today that BD stands with you today and every day as we work together to build a healthier, more equitable future for all Kenyans. Asante sana.
Good afternoon, everyone.
First, I'd like to say that this is truly amazing. The engagement and the way the room has been filled from day 1 to day 3, really something that I appreciate. And I think we all deserve a round of applause for ourselves. I represent Roche. I've spent the better part of 2.5 decades working in the healthcare industry. And from day 1 till today, the narrative is the same. We are losing people to cancer. From the first Cancer Summit last year, which we partnered with NCI, and I want to really, really applaud Dr. Meli and his team for this wonderful occasion. We've worked with you every step of the way. As Roche, it's important that we take the steps right from screening to diagnosis, to treatment, and even survivorship. Roche has a very unique capability because we have both diagnostics and treatment under one roof. And the best way to describe what we've been able to achieve is a few months ago when we signed what I believe is the landmark MOU with the Ministry of Health. Unlike many agreements in the past where maybe you focus on treatment in isolation, on diagnostics in isolation, we tried very hard to look at the entire spectrum of care. Starting from public awareness, we have survivors here, advocates. Our partnership starts from there. We've spoken about our healthcare practitioners, yourselves. How do we empower ourselves with knowledge? That MOU addresses that. We spoke about research, inclusive research. 2 days ago, we heard about how we are unique as Africans and how we need to be integrated into the global narrative about research and knowledge. You heard about how Roche has really integrated cutting-edge clinical trials right here in Kenya. We've heard about how diagnostics is important. We've heard about empower. I can go on and on and on. I will not belabor the point. So, while we've said partnerships and collaboration is the key word, actually I want to change that and say, no, it's about synergies. Synergies. We will bring our expertise. You will bring your expertise. And together, the sum total is more than the additive sum of our expertise. In conclusion, I want to say that I look forward to meeting all of you again, hopefully same time next year, Dr. Meli, in 2 years. And in that space, we'll be talking about the impact of what we started and what we'll continue with. We'll be talking about survivorship and changing the numbers that we saw in that space. Thank you very much.
Thank you very much, Mr. Bernard from AstraZeneca.
Good afternoon. It's good to be here at this part of time. And from AstraZeneca, we are proud to say that we are associated with all the initiatives in cancer care. And we are working towards this with our flagship program, which we call Cancer Care Africa. This is a dedicated vehicle of collaboration, of partnerships, of innovation, so that when we come to you with one solid foundation. And we ask for what we call sustainable partnerships. In Cancer Care Africa and what we do in AstraZeneca, we are looking at an empowered patient, an empowered member of the public who is aware about the situation, who is aware about the causative agents of their disease. And in this, we've supported programs with the NCI for national public education and patient awareness programs, and also worked with patient advocacy groups to be able to enhance awareness. Then this empowered patient should meet an empowered or a qualified physician who is knowledgeable in the methods of treatment. And in this sector, we've been able to help to train specialists through cross-border collaboration, about 700 of them. Physically, we've taken them to Egypt and some to South Africa. We have also trained 1,900 several layers of allied healthcare providers through virtual platforms. So an empowered patient who is knowledgeable has met a doctor who is knowledgeable, who knows what to do, but then they need to have the diagnostics capabilities. And in this area, we were the first in country to localize EGFR testing, reducing the turnaround time from the previous 3 months to only 1 week, when samples used to be sent out of the country. Now we have a platform in Aga Khan and another one at Moi Teaching and Referral Hospital. And for public patients, public referrals, this is free of charge. For patients referred from private facilities or private patients, we give these at a concessional pricing. And this we've been able to discuss with the partners, and work is in progress. The only sad thing is that even when we are offering it for free, it is not maximally utilized. The utilization is still less than 50%. So it's a challenge to all of us that this is an opportunity we need to exploit and capitalize on. Then finally, when we've already enhanced the diagnostics, we also did donated prostate cancer ultrasound guided biopsy machines. And it's good to see Professor Nyong'o here, because one of the machines we donated to Jaramogi, and we hope it's helping to serve our patients there. We've also helped to screen, and we donated through NCI, 10,000 PSA screening kits, and we are glad that we've been able to utilize about 9,500 of that within a span of 1 year. Lastly, when we've already gotten the diagnosis right, the patients will need medicines. And we have innovative solutions where, through our partnerships with in-country and out-country collaborations and charities, we are offering supported treatment plan, where we contribute a little of it, we ask the patients to contribute a little of it, and also charities and other donors are able to contribute a little bit of it. We are asking our partners in SHA, let's help the patient contribution, because sometimes we ask the patients to pay for only about 2 months treatment, and they can't afford that. And SHA says that they have a capitation and the maximum they can do is a certain amount. And we talked yesterday about innovative solutions. Let's be able to finance and treat solutions, not give a blanket commitment in terms of funding. Thank you so much.
Thank you so much. Dr. Kellen, representing Pfizer. Thank you.
Thank you. Not a doctor, but it's always nice when someone says I am. I also realize that I am standing in between lunch, so I will try and make this quick. But first off, I just want to say how humbled Pfizer is to be here over the past several days under NCI leadership, and frankly, over the past several days, having the opportunity to speak with such diverse leaders in the oncology space. Everyone in this room, from clinicians, research, civil society, to government, I am overwhelmed by the great work that you are all doing, and honestly very much looking forward to working with you all in the future. But just to share a little bit, so several years ago, Pfizer, in response to some of the inequities and access issues we saw with respect to our portfolio, announced the Accord for a Healthier World. And this was really to try and ensure that every medicine and vaccine wholly owned by Pfizer is accessible to people in 45 low and lower middle income countries. As soon as products are available and approved in other parts of the world, they're made available here too. And so under this agreement, those countries are able to access the entire Pfizer portfolio, several hundred unique brands across oncology, hematology, infectious disease, rare disease, vaccines, cardiovascular, pain, surgery, at a not-for-profit price to those countries and public sector. And actually, we signed an agreement with the Kenyan Ministry of Health in June enabling that access. So now the Kenyan Ministry of Health, in partnership with KEMSA, is actually able to procure from Pfizer these medicines. So we're incredibly excited because now the entire oncology portfolio, which is very relevant to everyone in this room, spanning breast, lung, prostate, rectal, is now available. And that now includes all of our innovative and genericized medicines. But it doesn't stop there. And we recognize we frankly could donate our medicines. It doesn't mean that the medicines will actually be used well, safely, and effectively. And so with that, we're really using this opportunity, and honestly this conference, to learn and get educated and to really figure out where Pfizer should be partnering moving forward. I personally believe, just given, quite honestly, the lack of donors and philanthropy in this space, that industry does have a very important role to play in increasing access to whether it's diagnostics and medicine, but also supporting in the much needed health systems capacity investments that we know need to take place. Whether that's on how do we identify patients earlier, how do we screen them, how do we refer them, how do we make sure that they have the right support and navigation as they move through the health system, how do we ensure that the right diagnostic and instrumentation and reagents are in place, and of course, how do we ensure that they're actually well managed when they are on treatment. So we're using this opportunity to have obviously discussions with NCI, NCCP, a number of different industry players, and obviously civil society and the facilities themselves to really figure out how we show up. So really this is an open call and an open invitation. If folks are looking to see how they can potentially work with Pfizer, we really invite you for that conversation. And really, we're humbled to even be a part of that conversation in the first place. So just thank you for having us here and looking forward to working with you moving forward. Thank you.
Thank you so much. Dr. Beatrice from MTRH.
Good afternoon. So I'm here on behalf of my colleagues whom we work together at Moi Teaching and Referral Hospital. As we may appreciate that this is a level 6 hospital that takes care of the better part of Western Kenya, and not just Western Kenya, but some countries that are neighboring Kenya, from parts of Tanzania and Uganda and South Sudan as well. So we do have patients who come from those countries, and this is a total of about 25 million Kenyans. So what are we doing in cancer care? So as the Hemato-Oncology Directorate at MTRH, we do have a mandate to take care of patients who are either coming in for diagnosis or have already been diagnosed with cancer, coming from this community that I have mentioned. And we do have all the services cutting across the continuum of care of cancer, from hematology services to the medical oncology services. We have a vibrant radiotherapy unit with the 2 linear accelerators. We also have a surgical oncology team that is able to guide the process of diagnosis through surgery. And also, in terms of prevention, we do have screening services, both for breast and cervical, and these are free of charge, and the services run from Monday to Friday. And how has MTRH done this? This has been through collaborative efforts over the years. Actually, for more than 3 decades now, we've had a very strong relationship between Moi Teaching and Referral Hospital, Moi University, and AMPATH, which is a consortium of American universities led by Indiana University. Initially, the focus was on HIV, but for the last 10 to 15 years, this has now moved to chronic diseases, and cancer falls under that. And what then has happened over time is growth in terms of focus in terms of improving cancer care. Through those collaborative efforts, we ended up building the Chandaria Cancer Center, and that is where all the services that talked about are under, so they're under one roof. It's actually a one-stop shop. When you come in, you don't have to be sent here, and there. You can get all those services under one roof. Apart from that, we have special programs that are targeted towards cancer treatment. We have a Burkitt's lymphoma program, we have a multiple myeloma program, a breast and cancer cervical program, we have a Kaposi sarcoma program, and all these programs, and the programs keep coming up depending on whoever is generating the idea, whether you're working in Moi University, in Ampath, or in Moi Teaching and Referral Hospital. Besides that, we are also committed to a training, and also apart from that research, we have a clinical trials unit under Moi University. And again, initially this was focused on just HIV and communicable diseases, malaria over the years. But now there's a push to focus on clinical trials that are targeted on cancer. Actually, we have submitted some proposals to some of our pharmaceutical companies, including Pfizer, Johnson & Johnson, and this is an area that is growing, and we hope to continue collaborating. And we were very excited actually to see the research projects that are presented through the support by NCI. We did submit our proposal. We didn't win, but we hope to submit this coming year. So thank you very much. We are committed as Moi Teaching and Referral Hospital to continue uniting our voices and taking action. Thank you very much.
Thank you very much, MTRH. Dennis from Zuri.
Thank you, and good afternoon, everyone. I'm here today representing Zuri Health. Zuri Health is a Pan-African digital health company where we offer technology-enabled health services. We are currently present in 7 countries in Africa, both in East Africa, West Africa, and Southern Africa. On the side of cancer, we are an implementation partner. We work in community screening of patients. These are mostly NCD-based screenings. We work with counties to identify their needs, and then we're able to organize end-to-end camps where they're able to screen patients. We have been able to screen patients in 40 out of the 47 counties, and we are currently conducting at least 2 camps every month, where on average each camp screens around 3,000 to 4,000 patients. So we are really big in that space. And when we do screen the patients, we also help them to navigate their journeys. We help them with linkage to care, and we do follow up and ensure that these patients, the ones who require treatment, eventually end up getting their treatment. We work with CHPs in the communities in terms of when we are running the camps, so that at least even those patients who are deep inside the community are able to be reached, and they are brought in for those camps. So our appeal is to those partners who require screening services at scale. We are become pretty good at it. We are experts, and we look forward to collaborating and working with any partners available who are looking to offer such services. Thank you.
Thank you so much. Can we give a round of applause to our team here? And now, because of our time, I think the other partners, what we'll do, we'll appreciate them from where they are. So I'm going to, call the various institutions, and kindly just stand wherever you are and wave, and we'll appreciate you. We know you are doing great work, and therefore I will start with Dr. Peter Nthiga of F&S Illumina. Let's appreciate F&S Illumina. They are the ones dealing with genomics. And we have Kenyatta University Teaching, Research and Referral Hospital, represented by Dr. Tracy Irura. Dr. Tracy, kindly stand where you are so that we appreciate your institution. We also have Mobilab. Mobilab is represented by Mr. Edmond Cheriot. Kindly stand so that we can appreciate you. Yes, there is. We have City Cancer Challenge, and CCAN is represented by Madam Beatrice Okumu. Beatrice Okumu, there she is. Let's appreciate them. We also have IntelliSoft. IntelliSoft, represented by Chelsea Karaoke. IntelliSoft. Thank you. Then we have Zenopia. Zenopia team. Yes, at the back there, we appreciate Zenopia. We have Savannah Global Health Informatics. Savannah Global Health, represented by Nisi. Nisi is right there. Thank you. We have NSDCC. NSDCC, thank you. We also have Council of Governors. We have Governor, Your Excellency, we appreciate you. And thank you very, very much. You've been here with us right from the beginning. Can we just appreciate him more? Yes, thank you, thank you, thank you very much. We have KENCO, Kenya Network of Cancer Organizations. The CEO is there, Madam Phoebe. We appreciate you. We have Glenmark. Glenmark. Yes, Glenmark is behind there. Let's appreciate them. We have Nairobi County Government, our hosts. We are in Nairobi County Government. Let's appreciate Nairobi County Government. We have Ruai Family Health. Ruai Family Health, representative right at the back there. We appreciate you. We have HCGCCK Cancer Center. Let's appreciate them right at the back there. Thank you very much. We have Cure Cervical Cancer Organization right here. We appreciate them. We have Scope Meditech. Scope Meditech. We appreciate in adventure. We have Kenya National Blood Transfusion, KNBTS. Yes, they are there. We appreciate you. Thank you very much. Texas Cancer Center. Right at the back there. Thank you very much. The Nairobi West Hospital. Right at the back there. Thank you very much. SHA. SHA. Yes, right at the back there. Thank you very much. Terumo. Terumo. We give them a round of applause in absentia. We have Change Biotech Limited. Change Biotech Limited. Right? Okay. We appreciate them in absentia. Last but not least, the Nairobi Hospital. Yes, we appreciate you, Nairobi Hospital, there. Thank you very much. And as National Cancer Institute of Kenya, we say that everybody has something to bring to address cancer prevention and control, right from the grassroots all the way to the topmost where we have the policy formulation. So at this point, therefore, I want all of us to stand and appreciate the great stakeholders that are in this room. The great stakeholder, if you are in this room, you are a great, great stakeholder. We want to appreciate you. Now, this one we are going to do in a very interesting way. Being a scientist, yeah, we have something called factorial. Do you remember that? So we are going to do 5 factorials. So this is how we are going to do. We are going to clap 1, 2, 3, 4, 5. Then we go 1, 2, 3, 4. Then we go 1, 2, 3, like that, up to 1. Okay? That is for you, from us to you, right? So can we start? Let's go. Very good students. I can see you're all A students, isn't it? Yes. So with that, I hand over now to the MC to take on that part. We really highly appreciate, even as my panelists are leaving the stage, we really highly appreciate, and we say one thing, that partnerships and collaboration is key. We look forward to forging great partnerships, that this summit is not just ending as a summit, but we are looking forward to actually partnership agreements, and not just partnership agreements, but that will be actionable to address cancer prevention and control. We are also looking forward to MOUs, that is a memorandum of understanding with various partners, various stakeholders. There are those who are not in this room, but they are also coming on board, and so we are looking forward to all that, forging great MOUs, great partnerships, and more than that, great action. Let us unite our voices and take action. And last, as I leave the stage, I want to recognize one partner. I know they are not here because they are having a separate event. That is Kenya National Highways Authority. Yes, they said they are building the roads to improve access. Access. So everyone is dealing with access. Yes, God richly bless each one of you. Thank you.
Thank you very much indeed, Dr. Emily. I mean, the team that was up here, there is a package for you, so please, do we have the gift hampers for our discussant? Are they ready? All right, they're working on them. Once they're ready, they have been organized. We are going to call you up here so that you can receive your gift hampers. Ladies and gentlemen, distinguished guests, we're almost coming to the tail end of this 3-day conference. And you do agree with me that for the last, and as I'm saying this, I request my co-host, Mashirima, to come up on stage, because we are very sad, actually, that we are going home. We're not very happy, but we have to go home, because I also know that you have to go home so that you can also attend to the people who rely on you. But we do appreciate so much. I've been saying this, that I have been an event moderator for so many events and for so many years, both in Kenya and abroad. And I have never been impressed by a meeting like this, where the room is full to capacity. In most cases, I usually see after the official opening, almost 70% of the people, they leave, okay? But you have been around here, you have been very, very instrumental in ensuring that this meeting is a success. I don't know how this happens. I don't know whether this is how doctors operate.
I think we should invite more doctors and professors to every other conference so that they can teach people how it's done.
Precisely. I think it's good. Are we allowed to become doctors like us? I mean, we are journalists, but it's not too late to change. For me, my background is I'm a financial and economic journalist, but I don't think I mind changing. I just need to learn a few of your jargons, okay? And then, I'll go through some trainings on how, to turn around my tongue and to open my mouth to pronounce those words. Otherwise, you've been phenomenal, and we appreciate you. See, hata mimi unipigie makofi. So hiyo ni yangu na Mashirima.
Thank you so much. Indeed, O'Brien is the life of the party, and it has been a pleasure doing this with him. and meeting all of you, having conversations during break, during lunch. And indeed, these are conversations that should not end. And they will continue, not just in conferences, but we need to speak about this issue that is cancer. How do we control it? How do we prevent it? How do we treat it? And to continue these conversations, there are other conferences that are coming up. We have the following that will be coming up in Kisumu, Oncology Nurses Society Conference, which will be in September of this year, 17th to 19th, in Kisumu County. Our hosts are here, so let's clap for them. We will also have the Kenya Hospice and Palliative Care Conference in Mombasa in February next year. And actually not finally, Kenya Society of Hematology and Oncology in November of this year.
When?
Oh, next year. Okay, in 2026. I think there's something wrong with the handwriting. It must be the doctors who did this. And finally, the National Cancer Institute of Kenya Summit, the third one, will be in 2027. Tupige makofi tafadhali.
Absolutely. I think details will be shared as to where the Kenya Society of Hematology and Oncology conference will be held. So those details will be shared. I think maybe they need to go to Kilifi. I don't know.
They do. Kilifi
or
is
Lamu,
beautiful.
by the way.
Yeah.
Or Lamu, yeah? Or Diani, by the way. Okay? I would actually want to be there. I would really want to see doctors swimming, how they swim. All right?
I think what O'Brien is saying, in all these conferences, please remember we are very good moderators. So look for us. Thank you so much.
Imeenda, sindio? Imeenda, ama namna gani? So we hope to see you next time as we take you through your program. This is what we do. So we don't mind also being called again to do this again. So enough of our marketing. Time now to be poematic, all right? We can also throw around some difficult words, okay? It's time now for poem, okay? And guess who is coming on stage for a beautiful poem?
Rachel Karaoke.
And she's coming on stage together with a battalion of cancer
champions.
Champions.
With lived experiences.
With lived experience. Wachana na hizi story unasikianga huko nje. Sasa, these one, they are coming here with lived experience. So, let's listen to them as they take us. All the cancer champions, please come on stage because your support is really needed as we go through this poem. So, let's put our hands together for them. These are the people who are giving us hope that cancer is not a death row. It doesn't mean that you're going to die because of cancer. Well, definitely you die at some point, but you don't have to die of cancer. All right? So please, cancer champions, just come. You want to do it from where? Oh, and then you come. Okay. All right. Sawa. Thank you.
Thank you. Habari zenyu. Mimi naitwa Rachel Karaoke. Miaka naye nimekula chumvi, niko na 53 years. Nashukuru Mungu kwa umbali amenitoa. Nilipatikana na ugonjwa wa saratani ya matiti ilikuwa 2021. Na nashukuru Mungu kwa sababu ya madaktari wetu hapa nchini Kenya. Mimi sijaweza kwenda India na tuko wengi ambao tumetibiwa hapa Kenya. Hii bendera yangu ya Kenya nilinunua wakati nilipata kansa, na baadaye ilikuwa 2021 after kuona matiti yangu imeshiringi after kuwekwa chemotherapy. Kwangu inaashiria kwamba tuko na madaktari hapa nchini ambao wanatutibu ugonjwa wa saratani na tunapona. Mimi hufanya poem. Mimi hufanya shairi pale hospitali kuu ya Kenyatta, huko ndiko mimi natibiwa. Na bado ukiwa uko na kikundi yako uniite, ama shairi uniite mahali popote nitakuja. Shairi yangu inakuanga ikienda kwa president wetu ili aweze kutupunguzia gharama, kwa sababu pale nyuma tumekuwa na shida sana na penye tumefikia tunaona mkono wa Bwana. Wagonjwa wote wa saratani twapitia tabu, gharama iko juu tumeshindwa kuidumu. Wagonjwa wote wa saratani twapitia tabu, gharama iko juu tumeshindwa kuidumu. Naomba Rais wetu Mheshimiwa Ruto utuhurumie. Naomba Rais wetu utupunguzie gharama. Wengi wetu twapoteza jamii zetu kwa ukosefu. Wengine wetu twapoteza wapendwa wetu kwa ukosefu. Bima ya afya ikiisha, matibabu pia hukwama. Na kuomba waziri wetu Mheshimiwa Ndware utuhurumie. Naomba waziri wetu tutengeneze maneno. Kanza ikipenya mwilini inatuacha hohehahe. Masikini hatuna matiti ili tuacha hohehahe. Na kuomba Rais wetu, Baba wa Taifa, utuhurumie. Naomba Rais wetu utupunguzie gharama. Daktari wetu hongera sana kwa kazi nzuri mnayofanya. Matibabu yetu ni hapa Kenya, India sisi hatujaenda. Na kuomba Rais wetu, Baba wa Taifa, uwakumbatie. Naomba Rais wetu watengeneze maneno. Ujumbe huu ukiupata, na kuomba Rais niketi nawe nikueleze mengi sana na machungu tunayopitia. Ujumbe huu ukiupata, na kuomba Rais niketi nawe nikueleze mengi sana na machungu tunayopitia. Na kuomba Rais wetu Mheshimiwa Ruto utuhurumie. Naomba Rais wetu utupunguzie gharama. Mimi hivi nimesimama mbele yenu. Nimepatikana na ugonjwa wa saratani 2021 na nimetolewa matiti zangu zote mbili hapa Kenya. Nilianza matibabu yangu hospitali kuu ya Kenyatta. Nashukuru hospitali kuu ya Kenyatta imekuwa ikinipa nafasi ya kufanyia shairi kule, na matiti zangu zilikuwa zikitolewa kulingana na vile mtu anasemanga watoto wangu wamewachana na mwaka moja. Hii matiti yangu ilikuwa inanifanya hivyo. Ya kwanza ikatolewa 2022 Januari, ingine ikatolewa last year mwezi wa Januari, na after sasa mwezi wa February. Na wakati ilitolewa, kusema kweli nilisikia vibaya sana wakati madaktari wetu walikuwa wamegoma na haikuweza kufuatiliwa vizuri. Mimi kwangu nikiona kivyangu, na nikaweza kufanya ile video ambaye ilienda sana, na nikashukuru madaktari wetu venye mlirudi kazini, kwa sababu kusema kweli tulikuwa tunaumia. Asanteni sana kwa kazi yenu nzuri.
Thank you so much. Please come on board. Come on board everybody. Raisi kufika hapa ni mkono wa Mungu. Please stand up and enjoy. Umetubeba haijawa rahisi kufika hapa. umenibeba, 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 ninaua Mungu, umenibeba, 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 ni mkono wa Mungu, umenibeba. so much.
Wonderful.
Thank you so much. As we stand here, Dr. Meli is the friend of survivors. Anatupenda. Na si kujisemesha, with the board of NCI, they've made it possible for us to attend this summit and facilitated our transport, something that has never ever happened. Can we appreciate you? Thank you so much, Daktari. One thing I know, I went to Bungoma, and one of the speakers said, Daktari wangu wako wapi? She's an ovarian cancer survivor. She did not find you. Then the MCA of Bungoma asked, Daktari wangu wako wapi? Olonyi is my witness. Daktari wangu wako wapi? So thank you so much for being passionate with that. We are so grateful. Thank you so much for calling us on the table. This is not the first time. When we entered, we went to Gong Hills. We said our issues. They are attended through MOH. We went to Serena with the former cabinet secretary. We lobbied, we said 300 is not enough, and then 150 was put on board. Kazi ya survivors na daktari. To our partners, we are so much grateful. Also, we are standing here, I'm adorning something. Sisi tumekataa kuomba-omba. Sisi tumekataa kuomba-omba. Sisi tunajifanyia kazi na mikono yetu. Most of us here are doing small businesses, omena, sukuma wiki, and we are being able to pay our share and move on. Our empowerment leader zipatikane, tusimame tuendelee. This is by Leshao. Leshanga. Where is Leshao? Lesha is an eye cancer survivor. She does this, the beads, the kiondos, you can see, the deras. Please support her. Akona booth pale nyuma. We have Mary Mwangi who does knitted prostheses, scarves and kofias. Ziko wapi simuonyeshani kazi. Hatusemi serikali saidia. Tunasema mtununulie tuendelee. Ndio tununue dawa na tulipe sha. Sawa sawa. We also have Joanne who is doing the passes. Hizi. Tafadhali hatuuzi pesa mingi. Na ningeomba tufukuze umasikini na ugonjwa hapa Kenya kwa kusupport. Kama hizi ziko hapa, kila mtu ainue mkono juu achukue moja moja. Mshipi umenunuliwa na survivors. Mshipi amenunuliwa na survivors. Patia yeye mshipi. Patia daktari mshipi. Hawezi kuwa natupatia Uber na sisi tutarudi mikono mitupu. Kujeni tushike nini? Picha survivor. Kujeni mshike mshipi ya daktari.
Yeah, thank you. And then after that, let's have a group photo of all cancer champions.
Thank
and
you
then,
so much. We also want to appreciate Kenko. Kenko iko wapi? Kenko wako wapi? Yes. And we did our elections the other day. And the board of Kenko, tuliweka survivors wengi kuliko watu wenye hawana lived experience. Why? The game changer is lived experience. Sawa sawa. Thank you so much. Mr. Mapelu tunashukuru. Mapelu in absentia, si ndio? Mapelu yuko? Hayuko. Haya Makomi tunashukuru. Catherine Washira tunashukuru. In the helm of Kenko, you've made good steps. Asanteni sana. Acha nipe feedback.
Thank you so much. In 1 minute, they forgot to say that Kenko and all these lovely people, we are organizing something called Relay for Life. This is a globally recognized grouping that we are going to have the survivors remembering their journey and championing for their efforts. So we'll be soon approaching NCI. Please book your calendar. 17th of October, where is Mwende? Mwende Mutiso, the friend of Dr. Meli, where are you? Yes, this girl is the current holder of the Scars to Stars Season 1. 17th of October, we are going to have another run. And we are hoping a man this time round. Wanaume mko? I hope this time round we'll get a man to hold it. Please mark your calendar 17th of October. They forgot to mention, and then Relay for Life Global coming up in 2026. Watch the space. Thank you.
Thank you very much.
Thank you very much. Just another call as we say thank you to what Dr. Meli has done. I'm just calling on all the government officials, all our partners. Sisi tumesema hatuombaombi, but the only request is this. We can see everywhere, everyone empowering the normal people. We are the people surviving, and we need economic empowerment for cancer survivors.
Thank you.
Sisi tusimixiwe na watu. I am talking about Uasin Gishu County. I'm talking about the eastern counties yenye walienda. Those counties, where are our leaders? Just to see economic empowerment for cancer survivors. Tujitafutie, tusitafutiwe na wengine. Thank you.
Thank you very much.
Last one. I'm wearing a colostomy bag. I run a group of people who use these colostomy bags. They are very expensive. But our organization membership fee is only 4,500 per year, which is the cost of only 4 bags. So please adopt an ostomate today. Thank you.
Thank you. Thank you very much. I mean, you realize we can go on and on and on, and we appreciate those sentiments. Please be seated as they take their photo, and then we welcome the CEO of our National Cancer Institute of Kenya to take us through the next and final step. Then we can break for lunch. Thank you very much indeed. Yeah, thank you for the photo. All right. A photo with the Governor of Kisumu, His Excellency Professor Anyang' Nyong'o. And the First Lady of Kisumu County as well. Asante sana. They're saying that you smile as they take the last photo. Very good. Thank you. Thank you. You may now take your seat as we welcome Dr. Meli to the podium. Asante sana. Thank you. And we are reminded that after lunch, there will be that interaction. You can visit the booth, get to understand the new concept, the new innovations, as well as you create network. Remember, the day is still very, very young, and there is no point of going home at this point. Get to hang around, get to know as many people as possible, walk around the booth, and of course, get to know the latest technologies in the fight against cancer. Asante sana.
His Excellency Governor Professor Anyang' Nyong'o from Kisumu County, and our advocate number one, our chair, Board of Trustees, the National Cancer Institute of Kenya, all the leaders this afternoon, our distinguished partners, very valuable, our survivors, our delegates who've honored us with this 4-day summit committedly. Good afternoon, ladies and gentlemen. I know we are at our lunch hour break, but indulge us with very few minutes. The hour is here, the time is here. Sad enough, as O'Brien said, that as a family, we are closing the second National Cancer Summit, for lack of better words. It's been quite a success. And it's been possible because we made it here from the beginning to the end. I really want to appreciate all of us for dedicating our time. I know we are very busy, but we've truly demonstrated that we are here for a reason, for a purpose, and for a cause, which we believe in. It is running in our veins, and I'm truly, truly appreciative on behalf of the National Cancer Institute of Kenya, which is the convener of this very successful summit. But it was only possible because of you being here today and those days. We have learned a lot. We've achieved our objectives. We've gone through very many sessions, beginning from Sunday when we had an outreach at Kongoni Primary School, where we were able to demonstrate that we are not just talking in boardrooms and offices, but we are truly in the community, as has been demonstrated by those who made great presentations here, including our colleagues from county governments. Allow me, ladies and gentlemen, to recognize and appreciate the team, great men and women who made this successful, the organizing committee that sat day and night to put this together. Can we give them a round of applause? It is rated one of the most successful summits, and thank you for your feedback. And just to formally recognize them, if they can quickly get upstage so that your guests who you have planned for this activity for the last couple of months can appreciate you. If you can come up front, kindly. It has been a multi-sectoral committee that was drawn from different institutions, and they have done a wonderful job. Do you agree with me? Have they? Let us clap for them. And I'll quickly ask them to just mention their name quickly and the institution.
My name is Ruth Charity Wanyonyi. I'm the Senior Principal Partnership and Resource Mobilization, National Cancer Institute of Kenya. Thank you very much all, and together as one, as we collaborate, we'll fight this cancer. Thank you.
Good afternoon, all. I'm Limo Habel, Communications Officer. Thank you for following us in our social media. Thank you.
Good afternoon. My name is Julius Kibichi. I will start in the Program and Logistics Committee of the summit.
Good afternoon, all. Beresis Natos, Principal Administrator, National Cancer Institute. Asante.
Good afternoon. My name is Lucy Midu. I lead the Market Access and Government Affairs, Roche. Thank you.
Good afternoon. I'm George Saikwa. I work with the National Cancer Institute of Kenya. I was in the Resource Mobilization Department. All the letters you got came from me.
Good afternoon, everyone. My name is Gladys Chesumbai Onyango, and I was in the Exhibitions Committee. I work at the National Cancer Registry.
Good afternoon, everyone. My name is Lynette Koskei. I work for the National Cancer Institute of Kenya, heading the Department of Information, Education, and Communication. Our main function is public education and providing free cancer screening. And for the summit, I worked under the Committee of Publicity and Communication. Thank you.
My name is Dr. Joan Simam. I'm the Head of Research and Data Informatics at NCI. I was the program manager, and I think I know all the names of the speakers, so apologies for the late night messages.
Hi everyone, my name is Mabuko Olum. I am a nurse and a health economist. So I work with the National Cancer Institute of Kenya in strategy and planning. And in the summit, I was assisting Dr. Joanne in the program. We are the ones who are making phone calls at night. Thank you.
Thank you. Good afternoon, everyone. I'm Emily Basito. I'm an epidemiologist, the head of Strategy, Planning, Partnership, and Resource Mobilization Directorate, and I was the chairperson of this beautiful committee here. Thank you.
Hello, everyone. My name is Crisantu Zwekesa. I work at NCI Kenya in charge of capacity building, and in this beautiful committee here, I also chaired Services and Exhibition Subcommittee. Thank you.
Good afternoon, everyone. Kenya Network of Cancer Organizations, Phoebe Ongadi. In this committee, we ensured there was money for this summit. Apologies, day one was little lunch. We are going to revisit today, okay? 17th of October, Scars to Stars, Season 2. Ukikosa, utachekwa.
Good afternoon, everyone. My name is Ruth Graham from National Cancer Institute of Kenya. I'm the Principal Human Resource Officer, and I was at the Service and Exhibition Subcommittee for this summit. Thank you very much.
Good afternoon, everyone. My name is Dr. Michelle Mwendwangu. I work with the National Cancer Institute as the head of Oncology, Health Products and Technologies. In the planning of this summit, I was in the Planning and Logistics Committee. Thank you for gracing us with your presence.
Good afternoon, delegates. My name is Joel Owino. I work with the National Cancer Institute as the head of Standards and Quality Assurance Directorate. And in this committee, I was in the Planning and Logistics.
Good afternoon, everyone. I'm Dr. Nashat Fadlun Nur. I'm a clinical oncologist, epidemiologist, working for the National Cancer Institute as the head of cancer prevention and control. And for this summit, I was part of the resource mobilization for this summit. And also, I was the engineer of the famous proverb, if a lizard decides to become a crocodile, they have to give up their climbing tree ability. Thank you.
Good afternoon. My name is Kevin Omolo. I'm a communication and public relations specialist
and a graphic designer focusing on health communication. In this summit, also a part of the Resource Mobilization Committee as a member, and also work partly with the Frontera Media, heading a fellowship on One Health approach.
Good afternoon. My name is Dr. Joyfrida Chepchumba, and I was the representative of the Ministry of Health in this committee. I was in the Planning and Logistics Committee, and it's been a pleasure to be here with all of you. Thank you.
Good afternoon, everyone. Tom Machoka, the Principal ICT Officer at NCI. I was at the registration desk. I believe most of you saw me. Yeah, thank you.
Thank you very much. I want to believe you've taken a photo. Okay. So Elias Meli is just the face, but behind all this work, it is this powerhouse that have made it possible. I have a communication before I call a few of our guests to make a few remarks, which I would like to read because the author is anonymous. In this summit, we need a summary of developments since the last summit in 2023. And in the next summit, we also need a report of what we will have achieved by then. This will motivate all of us as delegates, caregivers, healthcare workers, and champions. Thank you for planning this event, which is very successful. May God bless you. And I hope we will get certificates. So I want to assure you that yes, I know it's important. You have learned, you've acquired skills, and certifications is offered as evidence that you participated. So working with our team, we have all your registration details. You should be able to get your certificates. Ladies and gentlemen, we shall definitely, I am a believer of monitoring and evaluation. And therefore, what we have gained today, we had rapporteurs across all our meetings, including breakout rooms, and we have noted every little detail of remarks, asks that would require of us, and you will see a difference in the cancer landscape as we drive the cancer agenda in the country, working with all of you. We shall reach out to you again to work on the implementation jointly, just like we have done this morning. Allow me to also appreciate, I may not get another opportunity to stand here, our very, very able MCs, Mr. O'Brien Kimani, and one and only one, Mwashirima Kapombe. They have done an amazing job. We can do better than that, ladies and gentlemen. Thank you very much for honoring us. And by the way, they have done this work as a CSR extending to this service. Can we clap for them once more? Because they also believe in our cause. Ladies and gentlemen, these success stories that we are celebrating now, as we look forward to even more, the gains that we've made began from very humble beginnings. And when the history of how we got here today is written, there are very, very few people who knows that. I do not even know myself. I joined the bus midway. I would really wish to ask my friend and brother, Dr. David Makumi, to join us on stage and share with us where did we begin, what are the reflections, how has the journey been, so that all of us as we onboard before and now, we can appreciate the humble beginnings. You are welcome, David, and thank you for a job well done. He may not introduce himself well, but I'll allow him to add. David Makumi is one of the founding board of directors at the National Cancer Institute of Kenya. He does understand why the National Cancer Institute of Kenya was established by the famous Cancer Prevention and Control Act, which the signature of a very distinguished, honorable person, advocate number one, our professor and our governor, Anyang' Nyong'o. Can we clap for him? And it can never be a cancer meeting when Prof is not there. We do appreciate you, and, you know, salutation for you, Prof, and your family. David is also the executive director of Faraja Cancer Trust, which has really benefited our patients who are in dire need whenever they have challenges financially. I'll allow him to make the additional introductions. You're welcome, David.
Thank you very much, Dr. Meli, Excellencies, Professor Nyong'o, and First Lady, all protocols observed. I'm really very humbled to be introduced by no other as Dr. Meli. And I believe, I know many of the people in the audience, others I have met them in the course of the last 3 days. Mine is to offer a reflection. As I was being called, I thought I had somebody saying that you are that I'm the grandfather of advocacy. So grandfather sounds a pretty big title. And especially when I'm also speaking among our seniors, but I take that with profound humility. While the Cancer Prevention and Control Act was established, which established the institute, the very institute which is our host today, it was accented, the act was accented by President Mwai Kibaki on the 27th of July, 2012. I remember getting a call from the media. The media has been with us in this journey. And I was going for a meeting in South Africa and saying, unaweza sema machache, Rais Kibaki ameweka sahihi ile act of parliament. And I'm about to board. And I'm like, okay, what do you want me to say? Except say that it has been a long journey. And we were all elated, delighted. But the journey did not start on the 27th of July when the president accented the act. The journey actually began more than a decade earlier. Probably would not be here. When we see magnificent buildings, we very often don't think, who was the architect of this building? We don't think, who was the civil engineer? Who was the structural engineer? All we say, great interiors, lovely ambience. But behind that, there were people who worked really hard to lay solid foundations to be able to get us here and to continue celebrating the things that are happening within the cancer space. It was interesting because when we finished our first term, we were not reconstituted for another year. You know, again, we needed to push this and get as many politicians and everybody who could help because the board has lapsed And Dr. Karagu was stuck. You know, you couldn't move without a board and board decisions. And it took a whole year. And finally, we got reconstituted and under the government of Uhuru Kenyatta. And included in this board that was reconstituted was Bob Collymore of Safaricom. And everybody, I know my neighbors told me, you have Bob Collymore on the board, mambo ya cancer itakuwa sawa, you know, with the Safaricom and their billions. You know, things will just move smooth. Tragically, Bob passed away before we could even convene our first meeting. Yeah. And incidentally, we all know he passed from the same disease that he had been appointed to be part of the board. But persistence and resilience only come from having given the chance to work through difficult times. You know, it was a setback, but we did soldier on. A soldier on in terms of making sure we have constant engagement with the ministry and having a robust civil society movement. I think nearly 10 years ago almost, we brought the civil society together. I was the first founding chair. Am I now an emeritus? I've always wanted that title of emeritus. So I was the founding chair, and we had to bring every single player within the cancer space under the Kenya Network of Cancer Organizations. Yeah. We had to bring every single player who was in that space together. And I think Kenko boasts about 60 or more organizations. And that is why, 70. And that is why when Phoebe talks, or Philip talks, this hall you listen. And when Phoebe says, I'll be given 5 more minutes, you know, just going to happen. But in the interest of getting, there's a lot more that we have done. But I think having a robust civil society organization together to keep in check NCI and the government and everybody else in between is very, very important. But not just to point wrongs, but also to provide solutions. And that's why we are, as civil society, work as partners. Where things are going right, we work as partners. If things are not going right, we also point out what needs to be done. But as I conclude, we know that thousands of Kenyans continue to die from cancer every year, including this year. We know by the time you and I go to bed tonight after dinner, nearly 100 Kenyans will have lost their lives. And hundreds of others will have been told you have cancer. So even as we look forward to the 3rd National Cancer Summit, let's also remember the pain of loss, breadwinners, parents. Having started my career as an oncology nurse, I've sat with many grieving patients and families, people who have lost loved ones, kids who do not know who will be there to pay their school fees. And I remember when, I think it must have been like 2002 or 1, I was working with the Aga Khan University Hospital then, and I got a fellowship to go and do some oncology fellowship in Canada. And my employer was, are you really sure that this organization needs, you know, people like you at this point? Because even for organizations, it wasn't a priority. I nevertheless did go, and did go to do the fellowship, and I'm glad I did, because then we continue to contribute to stand with families and to make them productive citizens of our economy. We need to get them back. We must not be complacent, though. We have come a long way. So much have happened. We were fighting about 1 cobalt radiotherapy machine in Kenyatta National Hospital. Now I think we have RINAC all over, you know, in the regional cancer centers. That is something to celebrate. But we know that people will continue getting cancer unless we also invest in prevention and in health promotion. The ultimate tragedy is not the oppression and cruelty of bad people, but the silence of those who are good, the silence of those of us who know, and the silence of those who have the skills the capacity and the resources and end up doing nothing. I'm actually paraphrasing Martin Luther King, because we who have the skills must do something. It is incumbent upon us not to allow our women, for example, to die of cervical cancer as they are dying. It's almost borders, it's almost criminal to do that. In a day when we have HPV, we have screening modalities that we can prevent some deaths. We must do something, and we must do with a sense of urgency, without sitting down in comfort. Since I'm also an aspiring politician, I'm waiting for that part where you clap for me so I sit down. Thank you very much, ladies and gentlemen.
Another round of applause for David Makumi. If we don't have those who can tell us about the past, we may not know how to get into the future that we all desire, which is a cancer-free country. Thank you very much, David, for taking us through that. Allow me at this point to invite one of our very important guests this afternoon, who is going to make a few remarks, and I'll call my chair to take over from there. Professor Manoa Isipisu, who is a very distinguished personality in this country. He is a distinguished diplomat, journalist, and strategic communication expert. He began his career at Reuters, reporting on major African events like the Rwandan genocide and Somalia collapse. He later served as Deputy Director of Communication at the Commonwealth Secretariat, advising on media strategy and leading communication for global summits. Esipisu was also Public Affairs Advisor to the President of the African Development Bank. In 2013, he became State House spokesperson in our country. He was later appointed as Kenya's High Commissioner to the UK in 2018, where he served until 2024. He played a key role in negotiating post-Brexit trade deals, expanding consular services, and strengthening ties with Kenya diaspora. In 2024, he was named Diplomat of the Year by the Diplomat magazine and honored by the University of Manchester for advancing health research collaboration. It is the reason, ladies and gentlemen, would like to hear remarks from such a tall person who has served locally and globally to share some words of wisdom as we close this summit. You're welcome, Prof.
Thank you very much. Good afternoon, everyone. Thanks, Dr. Melly and the National Cancer Institute. Let me stand on established protocols. As you've heard, my name is Manoa Isipisu, and some of you may know me from my time as spokesperson at State House. Others might know me from my service as Kenya's High Commissioner to the UK. But today, I stand before you in a different capacity. As an ordinary Kenyan, deeply concerned about cancer outcomes in our country. As the Honorary Professor of Cancer Sciences of the University of Manchester, and as Executive Director of Voicing Africa, a platform committed to amplifying African voices on the most pressing issues on our continent at this time. Let me begin with the stark reality about which all of you have spoken or have heard in the last 3 days. That 70% of cancers in Kenya are diagnosed at stage 3 and 4. At this point, it is too late. At this point, treatment options are often limited, and for many, palliative care is the only path available. But it doesn't have to be this way, because we know that early detection saves lives, and we know that in this room, we have the capacity to do something about early detection. 5 years ago, which probably is why I am on this stage, I helped bring together the University of Manchester and Kenyatta University Teaching, Referral and Research Hospital, KUTRH, in what has become a truly impactful partnership. Together, they secured a 450 million shilling research grant from UK's National Institutes for Health and Research to study esophageal cancer, which, as you all know, is one of the most deadly cancers in our region. That work, the research around esophageal cancer between these two institutions, began in August 2022. A key innovation under this grant is the mobile endoscopy unit, bringing diagnostic tools directly to communities rather than waiting for patients to come to hospital. It has already been to Meru and Nyeri counties, and it is showing great promise in promoting early diagnosis. Another breakthrough is a one-stop breast cancer clinic at KUTRH, inspired by the Nightingale Center in Manchester. This model has reduced the time to diagnosis from 6 months to just 1 day. This kind of bold, practical solution is the type of thing we need more of. Next, let's talk about the future. And as most of you have heard or said, precision medicine is where we must go. We now have the tools to tailor treatment to patients' specific genetic profile. Genomics is the key, as you've heard, and we are already looking into this part of our esophageal cancer research in this collaboration between the University of Manchester and KUTRH. However, there is a missing piece at KUTRH. They do not have a genomics laboratory. The hospital, of course, already has world-class imaging, molecular pathology, and equipment like the Linac and CyberKnife. But without genomics, we cannot fully unlock the promise of precision medicine. A public sector genomics lab would allow us to understand the genetic mutations driving cancer in East African populations and to advocate for targeted therapies from global pharmaceutical companies. This is a gap we must urgently fill. Now, all those fellows you saw sitting here from pharma are not going to give you the right medicine at the right prices unless you can tell them what exactly you want and for what purpose. So this is a task that we must embrace and with a certain level of urgency. In terms of perceptions, we've seen encouraging shifts in public perception. Now, Mr. Makumi was talking about this 2012 decision, and I'll tell you why that was an important signature at that time. Back in 2010, a study in Bomet County revealed widespread misconceptions that some of you have heard about, such as that cancer was contagious or, in fact, was caused by witchcraft. Our recent studies in Kiambu, in Meru, in Nyeri, in Nakuru, and in Kisii counties shows a vastly improved understanding. It attributes this to advocacy and public communication, mainly on television. The researcher from Wajir told you the same, that perception is improving dependent on the information that is being shared. So that's the result of policy decisions like that one made in 2012 and public education campaigns that have followed. It proves that governments can move the needle when they choose to act. Of course, the big issue is that we need to get our governments to choose to act all the time so that no one is having to be pushed to make the right decision. Let me highlight one more partnership. The University of Manchester is supporting the new cancer center in Kisii, helping establish specifically a cancer registry. Why is this important? Because, as you heard from Wajir, without reliable data, we cannot measure treatment outcomes or allocate resources effectively. It's a fundamental step in delivering quality care, and one that I think we should be able to follow through. Now, because counties are present and my friend Professor Nyong'o is here, let me speak frankly. Health is a devolved function, so governors must step up. County leadership must invest in early detection, in community outreach, in cancer registries, and basic diagnostic infrastructure. This is not a task for the national government alone. All of us have a responsibility in this fight. All of us should embrace that responsibility. Don't wait for somebody else to act. Don't wait for the chaps in Nairobi to give you direction. Just don't delay. And don't pontificate. Just get the job done. We know what the job is and we know what is required to do it. Finally, I want to briefly touch on another engagement of mine, and that's with StanMed Global, a company called StanMed Global. Founded in Kenya in 2017, StanMed is pioneering digital health solutions from electronic medical records and telehealth to clinical research tools, all integrated into their flagship program, which is known as StanMed HealthNet. What's their current focus? Supporting Africa's cities of excellence south of the equator, beginning with Johannesburg and Nairobi. We are building a high-acuity Pan-African health network designed to provide precise, timely, and digitally supported cancer care. Our technology empowers clinicians with real-time evidence-based decision support, leading to better outcomes and reduced disparities. StanMed is open to partnerships and collaboration. If you share our vision of world-class cancer care for all Africans, we are available to talk. In closing, let me unequivocally emphasize that the path is really clear. Early detection, smart investment, local responsibility, data-driven care, and innovation at every step. So let's act together, let's act boldly, and let's act now. Thank you.
Another round of applause for Ambassador Professor Esipisu. It was worth that time, as we apologize for time far much spent. I'm inspired listening to him by appreciating that what matters most in life is we must have knowledge, skills, networks, resources, and reputation. If we have all those five, then we will have everything that we need. I wish, Ambassador, it was a KPI for all ambassadors in all these countries that they serve to mobilize resources to support our cancer initiatives. We would be having adequate resources as we champion for local resources. You've done great for the cancer space by being our ambassador at UK. And I want to believe that is a challenge that will diplomatically be shared through the relevant offices. Ladies and gentlemen, without the Board of Trustees of the National Cancer Institute of Kenya, which provides oversight for us as management, we wouldn't be here and we wouldn't have made this progress. We appreciate all our boards, from the founding board to the second, the third, and we are heading towards the fourth, including my predecessor, Dr. Alfred Karagu, who set the pace for a lot of work that we are doing here today. Allow me to invite our chair of the Board of Trustees, who would then introduce our other Board of Trustees and pick it up from there as we bring this to the close. We apologize for the time that is far much spent.
Good afternoon, ladies and gentlemen. While I was sitting at the table there listening to the other speakers, I had a notepad where I was writing a few things which I wanted to talk about. However, after the performance by the cancer champions, for me that topped it all. I mean, I did not see what I could be able to say after that. I don't think I want to delve into any further technical discussions, because I think everything that I could have said has already been said. You know, I've been accused of a few things in my life, but not being smart is not one of them. So, that having been said, though, I want to appreciate very much, and especially after David Makumi's presentation, I really want to appreciate and applaud the people who have come before us. I thought we had it hard, by the way. I'm realizing we've come a long way, and we are really grateful, because, you know, things to do with intensity will get you somewhere on the short term. But it's a consistency on the long term that is going to get things done. And in your case, I can see you had both spurts of intensity where you're demonstrating, and consistency and persistence. And that is what has gotten us here today, of course, in conjunction with people who have supported us, like Professor Nyang Nyongo, whom we cannot stop mentioning. Now, as a board, I think one of the things that we want to concentrate on is, I know we've come a long way. And Phoebe was reminding me the other day that I mentioned to her that my policy is eyes on and hands off. Of course, the hands stay off, but only as long as you're doing the right thing. The moment things start going wrong, we'll be all in your business. And if you want to know how much confidence I had in the organizing team and the NCI team, I actually came in on Sunday, late on Sunday night. And my own major concern on the flight was that let not a flight be delayed and let not me miss the opening day of the conference. It was never about, I don't know whether things are going right. The team, you can see, has done a great job, and I also want to applaud all the participants for your active contribution during this conference. As the board of NCI, we will continue doing our part. And I was joking at a previous engagement, I was telling people that as we serve, especially chairpersons and board members, we serve at the pleasure of the president, or the president of the pleasure of the cabinet secretary. So sometimes that gazette notice comes like the second return of Jesus. It comes in the middle of the night. You don't know when it is going to come, but one thing that I'm certain about is, for the time that we are here, we are going to do our part. We're going to make sure that NCI Kenya has the impact that it has, and like I've said in my earlier presentations, it is about people. It is about our patients, and that we should never lose sight of. And so without further ado, because I know lunch is long overdue, I'd like to welcome Governor Professor Anyang' Nyong'o to come and do the closing for us. Thank you.
Good afternoon, ladies and gentlemen. I will not say much because I think between me and lunch, there is a second. So I want to make sure that that second is not abused. That's one thing. Noah, thank you so much for such a wonderful speech. Really, really good, and all the speakers that have spoken today. And I want to thank you very much, National Cancer Institute, for this summit. It has been very educative, and I think we have learned a lot. But we must continue going on. There's a Luo saying, Kinda eteko, sinani elwen. You can write that down as your vocabulary in the Luo. Kinda eteko, sinani elwen. In English it means determination is strength. Resoluteness is the essence of struggle. Determination is strength. Resoluteness is the essence of